Good morning, everyone. Please join me in prayer. Let us pray. Heavenly Father, from whom all blessings flow, as we, the members of the Association of General Practitioners of Jamaica, and all other healthcare professionals assemble virtually this morning to discuss ophthalmological illnesses and explore some of the ethical considerations that affect our practices and our lives. Even more so during this COVID-19 pandemic period, we thank you for your presence, your mercies, your blessings, and for allowing us to be together once more for such an occasion as this. We thank you for our presenters who have agreed to give of their time and talent to this undertaking, and the pharmaceutical companies for their continued support. Guide us with your divine intelligence in our deliberations and give us knowledge, wisdom, and understanding so that we make the right decisions that will benefit all parties and persons and the nation at large. Father, bless us with healing hands and help us to do our work professionally with joy so that whatever we do will bring you glory and honor. May we see in the afflicted and suffering only a fellow human being in need. We thank you, Lord, for hearing our prayer through Jesus Christ, your Son and our Savior, in whose name we offer this prayer. Amen.
Good morning, everyone. And Dr. Donald Gordon, President AGPJ, we hand over to you now.
Thank you very much, Sam. Thank you very much, Senny, for that wonderful prayer. We welcome you all to this meeting. It's the final AGPJ meeting for the year. And we have assembled a wonderful program in ophthalmology for our GPs and anyone else who is attending. We welcome our sponsors. We welcome our main sponsors, R.A. Williams, for their support. And we welcome our associate sponsors, Indus Life Sciences and H2K, for your support. Welcome to the technical team by Oldgate, led by Samuel Aaron. A special welcome to all our presenters, Dr. Fields, Dr. Yap, Dr. Leiberg, Dr. Hastings, Dr. Jordan, Dr. Calder, Dr. Delahaye. Okay, I hope I have not missed any of the presenters. Dr. Leiberg. Okay, we welcome you all, and we're looking forward to a wonderful presentation. Now, question and answers will be submitted at the end of the session, after the presentations have been done, and there will also be quizzes, so you can respond to the quizzes and you can type your questions in the question and answer section. To get the ball rolling, we're also, as mentioned, Dr. Calder, who assembled his team of presenters. We thank you very much, Dr. Calder. Save us a lot of legwork, and we thank you very much. And we are looking forward to a wonderful presentation this morning. We're gonna get things off by having a presentation by Dr. Fields. Dr. Fields is going to be the first presenter this morning, and our presentation will be on common retinopathies. There's a little rearrangement of the agenda, but Dr. Field is going to start off with common retinopathies. Dr. Field, give her a short introduction. She's a fourth-year resident at UWI, graduated from the University of Maryland, where she studied a BS in biology. She graduated from the University of Guyana with MBBS and came at the UW to complete her internship. She enjoys playing the piano, violin, spending time with family and friends, and she's passionate about vision loss. We welcome Dr. Fields to do our presentation on common retinopathies. We'll hand you over to Dr. Fields.
Thank you, Dr. Gordon. Good morning to everyone. Apologies for the rearrangement. We have an emergency, so we'll get on with the common retinopathy and management of such. So today we're going to be concentrating on diabetic, hypertension, sickle cell, and retinopathy of prematurity. Now, diabetic retinopathy, this is what your fundus should look like, a nice sunset glow with a foveal reflex at your macula. Well, with diabetic retinopathy, it's a retinal disease and an end organ manifestation of the diabetes, a complication of both 1 and 2 that affects the retina of both eyes. It's caused by blood vessel damage, and initially you'll have mild, nil to mild symptoms, which can sometimes lead to blindness. The longer you have your diabetes and the less controlled the blood sugar is, the more likely you are to develop this complication bilaterally. It's a microvascular end organ damage that can be non-proliferative, and it has stages within the proliferative factor. You can also have clinically significant macular edema that can also be apparent and decrease the vision as well. Among patients aged 25 to 74, diabetic retinopathy is the leading cause of vision loss worldwide. By 2030, it's estimated that at least 191 million people globally will have diabetic retinopathy, and approximately 56.3 million will have vision-threatening diabetic retinopathy. Now, when a patient presents to you who has decreased vision loss and you look at the fundus, oftentimes you may see hard exudates, arterioles and venule disruption, hemorrhages, microaneurysms. This is just an algorithmic breakdown of the pathophysiology of it, where damage from leaky vessels then cause swollen retina and edema and exudation. Risk factors: long diabetic history, uncontrolled high HbA1c, hypertension, dyslipidemia, renal impairment, to name a few. Patient will come in complaining of floaters, blurred vision, photopsia, or vision loss. They may either have non-proliferative diabetic retinopathy, which can range from microaneurysms to hemorrhages in all 4 quadrants, or proliferative diabetic retinopathy, from where neovascularization then leads to vitreous hemorrhages and tractional retinal detachments. Diabetic macular edema is where hard exudates or swelling is located around the macular area. Here is just a breakdown. You may see ERMA, venous beading. You may also, as seen, little spots, dot blot hemorrhages and flame hemorrhages. Here, this is proliferative diabetic retinopathy, where you'll have the neovascularization. You'll see formations within, especially around the disc, or you may find them just in the mid-periphery. These then lead into vitreous hemorrhages and tractional retinal detachments. Prevention, control of the diabetic retinopathy is of utmost importance. It can do by preventing the uncontrolled diabetes, you can then save a patient's a patient's vision from being lost. Hypertensive retinopathy. Here, some may confuse it at times with diabetic retinopathy, but this is due to the fact that the patient has malignant hypertension and it's arteriosclerotic changes of the vessels that cause the chronically elevated blood pressure. So patient will complain of reduced vision, usually complications, typical symptoms of vascular occlusions or macroaneurysms, which lead to these reduced visual acuity. Risk factors: patient of African descent, increased age, essential hypertension being a family history, high salt diet, alcoholism, stress, and sedentary lifestyle. So malignant hypertensive retinopathy, patient has constricted tortuous arterioles, retinal hemorrhage, hard exudates, cottonwool spots are seen, retinal edema, and even disc edema. It is important, any sudden loss of vision, the BP needs to be checked and controlled, as that is the likely source of the vision loss. So to get deep, to just fine tune the examination, retinal hemorrhages can range from dot block hemorrhages to flame-shaped hemorrhages. Cottonwool spots, this is ischemia of the fibrous necrosis and fibrous, this is ischemia of the nerve fiber layer, secondary to fibrous necrosis and luminal narrowing. You'll see these little cotton spots, fluffy opacifications, usually closer to the arcade and the discs. Exudates occur later in a later course of the disease, and this is a result of the hemorrhage that has been reabsorbed. You have lipid accumulation, and oftentimes it's around you can see it in the periphery, but many times it's within the arcades, thus leading to macular edema. Disc edema is a result of leakage and ischemia of these arterioles supplying the optic disc that undergo fibrinous necrosis. So you'll see disc swelling as well. AV nipping, this is where your arterioles and veins, the veins are depressed by the arterioles, and in more severe cases, they may have abrupt, sharp angle changes. AV nipping is more significant, mostly near at the disc. So you have, using the modified Shee's classification of hypertensive retinopathy, you have your grading system. So grade 0, of course, no changes, leading into barely detectable arterial tortuosity, or AV nipping, grade 2. Grade 3, hemorrhages and exudates are being noted. Grade 3, disc swelling. Bloods, lab tests that are required. Bloods, echo, Doppler, ECG are important. The aim and the management is to reduce the BP. These patients are often referred back to general practitioners for BP control, especially if it's malignant hypertension. Again, the more likely cause of these vision deficits and the probability of them not worsening. One of the major complications that can result in sudden decrease in vision, a central retinal artery occlusion. This is due to, and often when patient presents, their blood pressures are in urgent hypertensive numbers, at which time a patient has literally 90 minutes to get to the hospital for us to try to preserve some vision. So again, hypertensive control is the key to prevention of all these retinal vein occlusions and ischemia. Sickle cell retinopathy. This is an inherited group of hemoglobinopathies that manifest due to sickle cell disease. So you'll have manifestations from sickle cell disease to the sickle cell trait. The mutations that are more than likely to cause an ocular manifestation are your hemoglobin SC disease or your sickle thalassemia or any variation of those. Patient is often of African descent, and there's usually a contralateral retinopathy as well. It's hypoxemia that leads to the sickling of these cells that then give you tortuous retinal vessels and decreased vascular flow. VEGF is then released. This leads the patient to have from non-proliferative sickle cell retinopathy to proliferative sickle cell retinopathy. The vaso-occlusion in the non-proliferative sickle cell retinopathy can range, you can note on the fundus, salmon patches, black sunbursts, angioid streaks, silver wiring, or ghost cells. These are occluded vessels within the periphery. So this is your salmon patch. It's a nice pink patch that's found on the retina, your angioid streaks, your black sunbursts, and this is a combination of salmon patch and sunbursts. So this is just the staging of proliferative sickle cell retinopathy. Here, the patient may just present with mild tortuosities. You have your AV malformations, then your C-fan formations of showing neovascularization, your vitreous hemorrhage with autoinfarction at times, but then these can then lead to traction from the vitreous, especially if the patient is young. Then you lead into a tractional retinal detachment with the vitreous bleeds, which are very difficult to return the patient back to any previous vision that they had before. So patients often need a fluorescein angiogram to determine where you are having the neovascularization, as well as where the ischemia usually is having a result, which is usually in the peripheral retina. So this is showing you the C-fans on an angiogram. You can also ask for an OCTA. Here you have the on Fondoscopy, where you look into the patient's posterior segment, and you'll see the C-fans with a little bit of autoinfarction here, and you have your peripheral avascularization or peripheral ischemia. Stage 4, patient presents with the C-fans, then burst, bleed, vitreous hemorrhage. You'll lead into tractional retinal detachments. So management, patient needs annual screening. So like with any of the other retinopathies, all of these patients should require at least yearly screening, yearly fundus screening. The diabetic retinopathy, for the diabetic retinopathy, there is the diabetic retinopathy screening clinics that have been opened up around the islands. These patients can be referred to those places in order to get yearly screening dates to be have their fundus checked annually. So an annual screening, a baseline OCTA is also recommended. Non-proliferative, you just observe, but the proliferative sickle cell retinopathy patients usually have the anti-VEGF. So you try to do laser photocoagulation. All of this is for the ophthalmologist. So retinopathy of prematurity. This is for any child. It's a vasoproliferative disorder of the retina that occurs principally in patients, in children who are preterm. This is due to the fact that the retina has incomplete vascularization by the time most of these children are born. Complete vascularization usually happens around the 36th week in vitro. At least 400 infants are blinded each year, 4,300 with serious retinal scars. And it's one of the leading causes of childhood blindness in the US. ROP, or retinopathy of prematurity, can occur when the retinal vessels have not yet completed their centrifugal growth all the way out to the aura, from the disc all the way out to the ora serrata, which is the very edge of the final edge of the fundus. These are chemically stimulated by new vessel growth called with VEGF, and until completion, vascular genesis may highly be vulnerable to any sort of stress, and that includes medication, especially oxygen. So a patient who premature birth presenting before 32 weeks with a birth weight of less than 1,500 grams should be screened. So this is just a algorithmic breakdown of the pathophysiology of the retinopathy of prematurity. So the risk factors, again, gestational age of less than 32 weeks, 1,500. So if any patient is discharged from NICU prior to that and has never had a screening done by an ophthalmologist, should be referred to an ophthalmologist for that screening. So oftentimes when they're exposed to supplemental oxygen or decreased vitamin E, or if there's a history of multiple births or an issue with multiple blood transfusions, these patients are at higher risk for retinopathy of prematurity. So there are 3 zones that we look that in order to determine complete vascularization, we look at 3 zones. Zone 1, which is circumferential around the disc and includes just the edge of the macula. Zone 2, we're going to the mid periphery, and the nasal aspect should be completed. In zone 3, all the way out to the completed temporal edge of the ora serrata. We look at the number of clock hours and whether or not the patient has plus disease. So this is just showing you the different stages of retinopathy of prematurity. Here we have the avascular retina and the now new vascularization from the disc leading out to the retina. This is a demarcation line showing the beginnings of ischemia. This is stage 1. Patient has a ridge, it's stage 2. The ridge or neovascularization starts to then invade into the vitreous, meaning that they're not flat on the retina, but they're now standing up into the vitreous. It's now stage 3. This stage 3 can then start to have traction and pull the retina partly off of the fundus, and you may have a detached retina, stage 4. So this is just another view of how to see it so that you can have a better idea as opposed to a 3D impression of what retinopathy of prematurity is at the different stages. Stage 5 being where the patient has a total retinal detachment and a vitreous hemorrhage accompanies it. Just another way of looking at it. So to prevent, you try to prevent as much as you can preterm labor, minimize the oxygen use, and prevention of all the other complications. Screening needs to be done within NICU when the patients are less than 32 weeks old. If the patient was birthed less than 32 weeks old or had a decreased weight of 1,500 grams. Patients are usually screened 6 weeks after birth. The end of screening is when complete vascularization of the retina has occurred. Patients are then, if there's any issues, the ophthalmologist then takes care of and determines which management is best for this case. So complications would be retinal dragging, glaucoma, late onset retinal detachment, myopia, strabismus, or amblyopia, or complete blindness for the child. So, and in summary, all of the above retinopathies were ocular manifestations of systemic diseases as due to ischemia and damaged blood vessels, whether via vasoocclusion, vasospasms, hypoperfusion, or poor circulation. And at the end, our body's way of responding to this ischemia is with VEGF, all of which eventually leads to retinopathy and vision loss. So hope that this ends my presentation. Thank you very much. Hope everyone was able to carry away something from that. Thank you again.
That was fantastic, Doc. Thank you so much. And we know that you have an emergency. As you prepare to have Dr. Liber do her presentation, there's a question from Dr. Isaacs in the Q&A. Just to confirm, patients with sickle cell trait are at risk for sickle cell retinopathy?
Yes, they are. Their risk is lower, but they're still at risk. We still do screen those patients.
Okay, perfect. I'm not seeing any more. Dr. Gordon, over to you as Dr. Liber prepares her presentation.
Thank you very much, Dr. Field. Excellent presentation and slides. And thank you very much for that expounding on the retinopathy of prematurity. It's one of the things that we're not very clear. And thank you very much. We know you had you had to make adjustment in your schedule to do this presentation. And thank you very much.
It was my pleasure. Thank you again. Have a good day.
Okay, thank you. Okay, our next item on the program is trauma to eye. And for that, we are going to have Dr. Liburd. I will just give a brief introduction to Dr. Liburd. She graduated from the UWI and is currently a second-year resident in ophthalmology at the UWI. Dr. Liburd, welcome on the program, and we look forward to your presentation on trauma to the eye. Thank you very much.
Okay, hi, good day. I'm Dr. Liburd, second-year ophthalmology resident at the University Hospital of the West Indies. Today I'll be doing eye trauma. So ocular trauma is a leading cause of preventable monocular blindness worldwide. A study that was done by Dr. Imaru et al., published in 2014 on the patterns of ocular trauma presenting to the University Hospital of the West Indies in Jamaica, concluded that the highest incidence occurred between the ages of 18 and 35. Males were more affected than females. The majority of eye injuries actually occurred at home, and a majority were caused by blunt objects, and most were accidental. Okay. Of note, these could have been prevented with the use of proper eye protection. Okay. So once life-threatening injuries are excluded or identified and treated, you want to identify any threats to the vision using a focused history and organized approach, which Dr. Yap would go into after. So specifically with details of trauma, you want to know what went into the eye or what happened, how it happened, whether it's low velocity or high velocity. You want to know when it happened, where it happened, and what the pre-injury vision was. So in terms of classification, you can have the nature of the injury, which can be mechanical, which we'll go into more detail, or it can be non-mechanical, which include chemical, thermal, and radiation. You can also have etiological classification, showing either accidental, self-inflicted, or occupational. So according to the Birmingham Eye Trauma Terminology System, they classified mechanical injury into closed globe and open globe. So with closed globe, there is no full thickness laceration. With an open globe, there is full thickness laceration. So closed globe is further classified into contusions, which are due to blunt trauma, or laminar lacerations, which are due to sharp injury. And with open globe, it's further divided into rupture, which is due to blunt trauma, and lacerations, which are due to sharp injury, of which this is further divided into penetrating, which can be a single laceration. So you have an entry wound, but no exit wound. You can have intraocular foreign body. So you have a retained foreign object within the eye, or you can have perforation, which is two full thickness lacerations. So you have an entry wound and an exit wound. So some of the things that we would see in terms of lid laceration, it can be full thickness or partial thickness. It can affect the lid, which is seen here. It can affect the lid margin, which is seen here, full thickness lid margin laceration, or it can affect the canaliculus, which is the lacrimal drainage system of the eye. Okay, it can be due to either sharp trauma or blood trauma. Management would include cleaning of the wound, irrigating and removing any foreign body that is there, depending on the mechanism of injury, if they need a tetanus booster, and you'd want to do lid laceration repair. In terms of the lid margin repairs and the canaliculus repairs, the ophthalmologist, you would want to refer to ophthalmology for this, because with the lid margin repairs, we'd want to make sure that the lash line is correctly opposed so that there's no notching in the lid margin when it's healed, okay? And for the canaliculus laceration, we want to recannulate it so that they can have a functioning lacrimal drainage system. So you're gonna have subconjunctival hemorrhage, which is where you have blood vessels that rupture or break between the conjunctiva and the sclera. Here you can note that you can see the full extent of the subconjunctival hemorrhage. And this picture here, you note that you can't really see the posterior extent of it. And if you're unable to see the posterior extent of it and it's bullous like this, you're pouring if the patient has a globe rupture. So in terms of specific to subconj hemorrhage, there's no treatment that is necessary. You can give lubricant drops if they're complaining of any foreign body sensation, but you want to reassure the patient that the subconjunctival hemorrhage resolves on its own, and you want to stop any elective use of aspirin or NSAIDs. So with corneal abrasion, you can have a scrape on the surface of the cornea. Okay, the symptoms that they may complain of include pain, increased tearing, foreign body sensation, blurry vision, redness, and photophobia. In this picture here, you notice that the cornea is essentially clear. You're not really able to tell if there is an abrasion or epi defect. So what you would use is a fluorescein dye, and you'll notice that there's fluorescein uptake here. So you see an epithelial defect, and this indicates a corneal abrasion. In terms of management, you want to put them on antibiotic drops, lubricating drops. You may or may not patch the eye for a few hours, depending on the extent of the abrasion. This is to prevent blinking, which can cause a shearing force on the healing epithelium. So for corneal laceration, it can be full thickness or it can be partial thickness. In this picture here, you can notice that this is a full thickness corneal laceration, The pupil is irregular and peaked towards the wound, and you can actually see iris prolapse through the wound here. Okay. If it is an open globe, like in this patient here, you notice that the pupil is round and regular. What you would do is instill fluorescein dye into the eye, and you'll notice what's called a sidal positive test, which indicates an open globe. So what it is that the aqueous humor is actually leaking through the wound, the corneal wound, and you can see the dilution of the fluorescein here. So this indicates a sidal positive test, which indicates an open globe. So in terms of this management, you'd want to avoid any pressure on the globe, and you'd want to place an eye shield, and you'd refer to the ophthalmologist. We'll start them on antibiotic eye drops. Sometimes we can use a contact lens depending on the size of the wound, or we can repair the laceration. So with corneal foreign body, it can be superficially adherent or embedded in the cornea. These can vary from wood to metal to glass, sand, etc. It's usually a low velocity injury. They might complain and say while they were walking, they noticed the wind blew something into their eyes, something along that line, okay? Here you can see a metallic foreign body on the cornea here. And what we want to do is for removal of the corneal foreign body. If it's superficially adherent, sometimes irrigation can help to remove the foreign body, but if it's embedded, we'd have to remove it using a needle with an anesthetic eye, okay? Of note, you would want to also invert the lid because you can have foreign bodies that are on the upper eyelid. So if you don't remove them, they can have repeated trauma to the cornea, and we'll put them on antibiotic eye drops. For a high femur, this is blood in the anterior chamber. Symptoms may include decreased vision, photophobia, pain, and redness. In terms of so you can see the high femur here and a larger high femur here. In terms of management, you want to place an eye shield on them because you don't want the patient rubbing the eye or anything accidentally hitting the eye. We usually limit their activity and say bed rest. They want their head elevated at a 45-degree angle. We'll start them on steroids to help with any inflammation in the eye. We'll also put them on cycloplegic agents. This is to prevent ciliary spasm, which can cause pain, and also to prevent pasteurization. That is when the iris, which is the color part of the eye, becomes stuck onto the lens, okay? You'd want to follow them up closely because they're at risk for an increase in intraocular pressure. If we notice that they have an increase in the intraocular pressure, we'll start them on anti-glaucoma medication. And they're also at risk for rebleed. So you'd want to avoid any aspirin or NSAIDs. We'd also follow them up in case they may need surgery, which we would do an anterior chamber washout. Of note, for sickle cell patients, they're very susceptible to glaucomatous optic nerve damage and central retinal artery occlusion with a slight increase in the intraocular pressure. So we'd want to know their sickle cell status. For traumatic anterior uveitis, it can just be the inflammation of the iris, which is called iritis, or inflammation of the iris and the ciliary body, which is iridocyclitis. They can complain of photophobia, decreased vision, floaters, and pain. You can see some redness or what we call a circumciliary flush, which is around here. In terms of management, you want to put them on cycloplegic agents. This is to prevent the ciliary spasm and any posterior synechiae from forming. And you'll also put them on steroids. This is to help with the inflammation. And we'll follow them up closely because they're also at risk for getting an increase in the intraocular pressure. In terms of the lens, you can have a traumatic cataract. It looks like a stellate or a rosette shape, you can see here. It may develop years after trauma though. You can have a sublux lens, which is partial zonular dehiscence. So the zonules are what keeps the lens in place. So if you have partial rupture of it, you can get a sublux lens, or you can have complete zonular dehiscence. So the lens can be displaced anteriorly, which is shown in this photograph here, or it can be displaced posteriorly in the vitreous, okay? The definitive management is surgery. For vitreous hemorrhage, you can have symptoms of floaters or decrease in vision. This is a picture here showing vitreous hemorrhage. In terms of management, if we're unable to see, what we do is a B-scan ultrasound to ensure that the retina is flat, because if it isn't flat, that's a different management. You'd observe them, and you tell them to sleep at a 45-degree angle. And if it's persistent, usually over months, then we'll do surgery to remove the blood. So we can also develop what's called a retinal tear or retinal detachment. They'll complain of photopsia, so they'll see flashing lights, or floaters, or a sudden onset decrease in vision, which is seen with the retinal detachment. Here, this picture depicts, here you can see the retinal tear here. And you notice that this area here is a bit paler than the rest of the retina. This is the retinal detachment here. So you want to refer to an ophthalmologist immediately. The management varies depending on what we're seeing. So if you have a tear, you can do laser treatment or surgical treatment. And for retinal detachment, depending on where it is, you can also do laser surgical treatment. So specific for an open globe laceration, which we had said included the penetrating, intraocular foreign body, the perforating, and the globe rupture. With the subconjunctival hemorrhage, you are not able to see the posterior extent of it. So you're carrying a globe rupture for those patients, and you notice that the conj is quite bullous as well. For corneal or scleral laceration, you can have a prolapse uvea. So this picture up here is showing the corneal laceration, and you can see the iris that's prolapsed through the wound. Here is showing a scleral laceration, and you can see the uvea is prolapsed through this wound here. So another clue is the pupil. It's irregular. It may be irregular or pointing towards the wound, which is seen in this picture up here. For intraocular foreign body, it might be obvious, as seen in this picture here, or you might not be able to see it, but they usually give a history of a high velocity injury. So like metal on metal, or they're hammering something, okay? For patients that you're not sure about that have an open globe, remember we said you can instill fluorescein dye to check for a positive Seidel test, and this would indicate an open globe. In terms of investigation specific for intraocular foreign body, you want to do a CT orbit to locate the location of the foreign body. In terms of management, you do not want to put any pressure whatsoever on the eye, so no eye patch. What you want to use is an eye shield. So here is the eye shield that we usually use in clinic, but if these are not available to you, you can make your own eye shield. Here they're showing a styrofoam cup that was cut, and it's taped to the patient's face. Here they're showing sunglasses, which is also taped to the patient's face. This is to prevent the patient from accidentally touching the eye or anything from accidentally putting pressure on the eye. You want to ask the patient if they can limit coughing and straining, because this can cause expulsion of the contents of the eye out through the wound. In terms of medication, you want to give them any antiemetic if they're feeling nauseous or having vomiting. You give them analgesia for any pain that they're having, depending on the mechanism, if they need a tetanus booster, and you can also give them a prophylactic systemic antibiotics. You'd want to refer to the ophthalmologist immediately, where we'll do our definitive management, which is surgical repair, whether it's globe repair or evisceration, depending on the extent of it, and removal of the intraocular foreign body. So with chemical injuries, alkali is worse than acid because it penetrates the cornea more rapidly because of saponification. So with the symptoms, they can complain of blurred vision, pain, increased tearing, or redness. So the Roper Hall classification system is simple, and it also gives you an idea of what the prognosis is going to be. So with grade 1, which is a good prognosis, there is no limbal ischemia, and you have epithelial damage. So you'd want to stain with fluorescein to check for that damage, okay? For grade 2, the prognosis is also good. The limbal ischemia is usually less than 1/3. And with the corneal involvement, you can have a mild haze, which is seen in this picture here, but you can also appreciate the iris detail. For grade 3, it's a guarded prognosis. The limbal ischemia ranges from 1/3 to 1/2. You can have a total epithelial loss with corneal haze that obscures the iris detail, which is seen here. And grade 4 is a poor prognosis. So the limbal ischemia is greater than 1/2. And you notice that the cornea is opaque and you're unable to see iris and pupil details. In terms of management of anybody that has a chemical injury, you want to irrigate immediately, and you want to achieve a pH of between 7 and 7.5. So you can use normal saline or lactated ringers, but if this is not available, you can use clean tap water. If the patient has a contact lens in, you'd want to remove that, as the chemical can get trapped between the contact lens and the cornea, okay? This picture here is showing an example of of doing irrigation to the eye. So if the right eye is affected, you'll ask the patient to slightly tilt their head to the right, because you don't want the fluid that you're irrigating from the right eye to go into the left and cause a chemical injury in the left eye, okay? For mild injury, which is between grades 1 and 2 for the Roper Hall classification, we give antibiotics and lubricants. For severe injury, which is grade 3 to 4, we give antibiotics, lubricants, steroids, and ascorbate. Usually they may have to be admitted to hospital as well. So the most rare complication of chemical injury is permanent damage and vision loss. So you want to ensure that you wear protective eyewear during any risky activities, such as anything with high velocity or chemicals. With high velocity injuries, you want to make sure that the lens is shatterproof, so you can use a polycarbonate lens. So there are different standards for the eye protection. These are just 2 examples of that. So the take-home message, for significant eye injuries, it can lead to permanent visual impairment, and rapid recognition of serious eye injuries and early involvement of ophthalmologists are critical to ensuring the best possible vision outcome. And you'd also want to make sure that proper use of eye protection is used during these high-risk activities, as it can prevent the potential of the eye injuries by up to 90%. These are my references. That's it.
Thank you very much, Dr. Liebert. Very clear and precise presentation on a common problem seen in general practice. And we know you made great efforts to do the presentation, and thank you very much.
You're welcome.
Okay, our next presenter will be Dr. Jessica Yap, and she's presenting on history and examination of the eye. Once again, we apologize for the order in which things were done, but it was due to certain circumstances. Dr. Yap is a graduate of Campion College. She completed her MBBS at the UWI in 2016. Her interest is in surgery and prevention of eye care promotion of eye care in Jamaica. She enjoys tennis, violin, reading, and dancing. Okay, we welcome Dr. Yap to do a presentation on examination and history of the eye. Dr. Yap, over to you, please.
Okay, thank you, Dr. Gordon. So good morning, I'm Dr. Yap, Jessica Yap. I'm, as he introduced me, second year resident at University of the West Indies, Mona, and I'll be presenting on the fundamentals of eye examination and history. Okay, so this is my outline. So eye-related complications or complaints make up about 2 to 3% of primary care office visits. It is therefore essential for the family or the general physician to be able to respond to these patients and to recognize when it is necessary to refer them to an ophthalmologist. It is very important to recognize if the condition is sight-threatening and requires urgent referral to the ophthalmologist. So after this presentation, you should be comfortable to approach the patients with the eye complaints, recognize and provide care for common eye conditions which can be managed in the primary care setting, recognize eye conditions which require management by the ophthalmologist, and also make appropriate referrals to the ophthalmologist. In terms of the history, it follows the general outline that we do for all histories. So we start with our presenting complaints, with our history of presenting complaints. Of course, we include our past ocular history and ocular medications, do general medical and surgical history, medications, allergies, social and a family history, and also a review of systems. In terms of the ophthalmic history, we go quite in detail. It's very important to ask about any systemic illnesses. So anything that can affect the eye, diabetes, high blood pressure, high cholesterol, any viruses such as the torch viruses, HIV, okay, very important. Also any autoimmune conditions. If they had any decrease in vision, that's a very common presentation that people come in for because of their eye. So if they come in because of decreased vision, you want to know how long has the decrease in vision been? Where is the decrease in vision? Does anything make it worse? Does anything make it better? Do they know what caused it, or have they ever had it before? Okay, you also want to know where does the decrease in vision occur. So if they're having any shadows or curtains, and in which parts of the visual field is it? Is it in the superior, inferior, nasal, or temporal aspect of their visual field? If there's any pain, you want to know, has anything made the pain better or worse? When did the pain start? Where is the pain located? Whether it's in the eye itself when they blink, behind the eye, like retrobulbar, if there's any headache associated, any jaw claudication, pain while chewing, any scalp tenderness, right? If there's any redness in the eye, any aggravating or relieving factors, sometimes eye drops such as prostaglandin analogs may cause redness to the eyes. If there's any discharge, you want to know the consistency, the color, the frequency of the discharge. When does the discharge occur? Did it start in one eye, went to the other eye? Does anybody else around them close by have a discharge as well? If it's associated with any epiphora, that's like tearing, increased tearing. Any foreign body sensation, trauma, if it's unilateral or bilateral. If it's a bilateral history, you may be suspicious of a systemic cause. So just to go back, in terms of trauma, if they've had any trauma, such as if a nail has hit them, you want to make sure you rule out an intraocular foreign body, so they may need a CT scan. So if they've had a previous episode, it might clue you into what is causing this episode now, or how you may have to treat it, or what you should do for the patient. If there's any visual disturbances, such as any photopsia or flashing lights, that's the same thing. Any floaters, if they notice that straight lines are now appearing wavy, which would clue you into like a macular problem. If they have any known ophthalmic disease, if they use glasses or contact lens. So if a person gives a history of wearing contact lens all the time, and they're coming because of pain and redness to the eye, you're going to be very suspicious of something like a corneal ulcer. If there are any eye drops, any prior eye procedures, prior eye trauma, which could clue you into why the eye may look like it is looking right now. If they have eye trauma from a long time ago that may have not been treated. If they have a family history of eye disease. Okay. So common chief complaints that are decrease in vision, visual disturbances, ocular pain or discomfort, abnormal ocular secretions, abnormal appearances. So whether the eye is very red, or the eye seems to be bulging forward, or there's any abnormal appearances of the eyelids where it is very inflamed or puffy, or they notice a growth on the eyelids, or any history of trauma. Okay, so in the GP practice, these are common things that patients may come to you with. In terms of the history of presenting complaint, this is just an example. If the patient comes in because of loss of vision, of the questions that you should make sure to ask. So you want to know, when did the loss of vision occur? If there are any associated systemic illnesses, if it is sudden or gradual loss of vision, any aggravating, inciting, or relieving factors, any pain, if it is a transient or persistent loss of vision, if it is in one eye or both eyes, and you should characterize the loss of vision, whether it is blurred vision, if it is dim vision, or if it is distorted, okay? And also, where in the field is the vision loss, if they can identify it. So sometimes they may say it's a central field of vision. Sometimes they may say, oh, it started superiorly and then it migrated inferiorly. Okay. So in terms of what you will need, your resources for eye examination in your practice. This should include a Snelling chart or another type of visual chart, but I mentioned this one because it's the most popular one. A magnifier, preferably at least a ×8, a torch with a blue filter. Usually the ophthalmoscopes have a blue filter in them as well. Fluorescein topical anesthesia, which you may need sometimes for treatment of, say, a chemical injury, and a topical mydriatic if you want to do fundoscopy. Okay. In terms of the examination, we have a pretty systematic method of doing examination. So cannot emphasize enough how important the visual acuity is, especially when you're referring patients. Visual acuity is like blood pressure for hypertensive patients or GMR for diabetic patients. Okay, so very important. I will get into a little bit more about visual acuity later. So the adnexa, so of course, any surrounding structures of the eye itself, especially depending on the patient's complaint. You look at the eyelid, the conjunctival sclera cornea, the anterior chamber. So the anterior chamber is the part of the eye in between the iris and the corneal endothelium. Okay, so the iris and the corneal endothelium, that is the anterior chamber. Pupil, iris, we also look at the lens, the fundus. We may do visual field examination and extraocular movement examination depending on what the patient came in for. And I put other there because it can include some things like if you're going to check for carotid artery bruit, say if the patient came in because of a central retinal artery occlusion or so. All right. So this is an example of the Snelling visual chart. So as you can see, there are letters in the middle, and as you go down, you can see the letters get smaller, and on the right-hand side, you can see that there are 1, 2, 3, 4, 5, 6, 7, and then you see other numbers that has a numerator and a denominator. So essentially, the 2200 means that the numerator means that that is the distance the patient should stand from the chart. So the patient should be 20 feet away, and the denominator, the 200, means that at 20 feet, the patient is seeing what a normal person would see at 200 feet away. Okay, so let me just go over it one more time because visual acuity is very important. So the numbers on the right, you have a numerator and a denominator. The numerator represents the distance from the chart, so it should be 20 feet away for this particular chart. And then the denominator represents the number of feet away from the chart that a normal person would be able to read that letter from. So if the patient is seeing 20/20, that is a DEF POTEC, that means they have normal vision because they are seeing what the normal person would see at 20 feet away. All right. I hope you guys understand this. All right, so this is a little video to show how to test the direct and consensual pupillary reflex. So this is important to check. So when you shine the light to one eye, say you shine the light to the right eye, the pupil should constrict. That is a normal direct response. When you shine the light to the right eye and the left eye, the left pupil constricts, that is a normal consensual reflex. Anything deviates from what I just said in terms of which pupil should constrict, you refer that patient. Okay, so you can see that the light is being shown into the right eye now, and both pupils are constricting. So that's a normal direct and consensual response. Okay. All right, so I just included this picture here to demonstrate to you how we would examine the eye. So as you can see here, this person, we'll start with the eyelids. The eyelids are quite inflamed, they're erythematous and a bit swollen, and you can see the eyelashes themselves are a bit matted together, and they have a discharge, like a yellowish, crusty discharge. Then we move on to look at the conjunctival, which is mild to moderately injected, right? And then you can see the cornea is clear, and we can mention that the cornea is clear because you can see that the iris you can see the iris detail, right? And then the anterior chamber is the area that I had mentioned in between the iris itself and the corneal endothelium. So that area right there, if you can look in the mirror or if you have somebody beside you, you will notice that you can notice a space. You will see an obvious space in between that corneal endothelium and the iris, and that is what we refer to as the anterior chamber. So that is a location where you would more see like a high femur or a hypopion if you were to look out for it, right? So we can see this one is formed. Formed meaning it's not flat against each other. So we notice that the iris is not pushed up against the corneal endothelium, which would mean that the anterior chamber is flat. Okay, so with your GP examination, most likely you would just comment whether it is formed or flat, or if there's anything obvious in there, like a hypopion or a high femur. Okay. Also, we can see just grossly, the lens in this eye appears to be clear, right? And if you want to comment on the pupil here, I'm not sure if they got dilating drops or the conditions in terms of if there was a lot dim light or so, but this pupil is maybe about a 6 millimeter dilated pupil. All right, then we'll go on to the fundoscopy. I hope you all still have your ophthalmoscopes from medical school and use them. So when you do fundoscopy, sometimes you'll be able to see all of this, well, the posterior pole without dilating the patient. However, once there are no obvious contraindications to dilating the patient, such as acute closed-angle glaucoma or very high blood pressure, then if you have mydriatic agents, you can go ahead and dilate the patient to have a better view. So when you look into the fundus of the patient now, you're going to look for certain things like the optic disc, the macula, and the fovea. So in terms of the optic disc, you can comment on the margins of the optic disc, the color, if it is pale, if it is pink, and the cup to disc ratio as well. You can also comment on the vasculature if it looks normal, all right? So this one, for argument's sake, it has well-defined margins. The cup it's pink, and the cup to disc ratio is about 0.2 to 0.3, right? And the vessels look normal. The macular area here looks normal as well. They have put a little label right by the fovea where I would expect the foveal reflex to be. But in a normal patient, you should see a bright light coming from the fovea, all right? So that represents the umbo, or the central depression in the whole macula. All right, so remember when I spoke about instruments that you need for examination, we spoke about the Fluorescein as well. So this is an example how Fluorescein would look in a person who has an epithelial defect. So the picture on the left, picture A, shows a Fluorescein on an eye without the cobalt blue staining. So this is just putting the Fluorescein on the eye with an epithelial defect. And on the right-hand side, picture B, we see with application of the cobalt blue filter. So you see a well-demarcated region, right? And this represents an epithelial defect. So epithelial defect can range anywhere between a corneal abrasion or a corneal ulcer. All right, so very important, if you see any patient like this, don't give them any steroids, because a lot of times steroids can make these conditions worse. And remember, sometimes antibiotics, there are drops with antibiotics as well as steroids, like Tobradex and Picodex. So they still contain a steroid. So important not to give these patients those eye drops. Okay, so this is another short video I would like to show you in terms of how to examine extraocular movements. Okay. So essentially have the patient sit about arm's length away and ask them as possible, looking straight at you. And then you're gonna move your hand in the form of an H and watch close to their extraocular movements, and ask them as well if they're seeing more than one at any point in time. Okay, so he's watching the patient's extraocular movements carefully. So this looks at the movements of the muscles. Okay, so if you see any defects or any lagging of any muscle, then you can document and refer the patient. Okay, I have another short video here, how to test confrontational visual fields. So say, for example, even if it's not a patient coming in for an eye problem itself, say they have a pituitary adenoma, you guys remember, they may get a bitemporal hemianopia, right? So you still have the patient sitting about arm's length away, and if they cover their right eye, you would be in front of them and therefore cover or close your left eye. Okay, and you check their visual field in reference to your visual field, providing that your visual field is normal. So you can either use amounts of fingers like he did and ask the patient how many fingers are they seeing. Ensure that the patient is looking straight at you. Remember, ensure. Or you can do one finger and move the finger from outward and bring it in and ask them when they start seeing the finger. So remember to test nasal, temporal, superior, so you can bring it out and bring it back in. Okay? All right. So now we have done history and examination, and now I have included a couple of clinical cases so we can apply history and examination. Okay, so I hope you guys are following. Okay, so some of these things Dr. Liebert had gone through in a little bit more detail, but I'm just gonna go through a little bit how the patient may present and what you should do with the patient and in terms of triaging the patient. Okay, so this person may have come in because of photophobia, that's pain in the light, and maybe a foreign body sensation. As you can see here on examination, the conjunctiva is mild to moderately injected, right? And you can see there is an opacity on the cornea itself, right? So this person has a corneal foreign body. It looks metallic in origin. You can see a little rust ring around it. So typically this patient may be a welder who did not wear their protective glasses, right? So if you see this patient, you should refer this patient to the ophthalmologist. And also if you suspect a foreign body, but you're not sure, you can also stain with the fluorescein to see if you see any defects, okay? So use the fluorescein and the cobalt blue if you're not seeing any foreign body, but you really suspect that the patient may have a foreign body. All right, this patient may have presented because they were splashed with a whole lot of chemicals like bleach. And as you can see here, all of this area is completely white. So remember in this picture here, we saw this one was quite red. All the vessels are red and engorged. But this one, you can see it's basically completely white. You're not really seeing any vessels. And that is because this person has a limbal ischemia. So the limbus is the area right here in between the cornea and the sclera, the cornea and the sclera, the outer extent of the cornea, and it actually contains the stem cells for corneal epithelium. So that part is very important. And if it is white here, that is very bad, very poor prognosis for this person. But if you get any patients with this presentation, a chemical injury, what you should do is irrigate, okay? So at least 2 liters of normal saline. You can also use sterile water if not available, all right? And you're gonna irrigate until you notice that the pH. So because of resources, you can use the urine pH strips. I brought one here. I hope you can see to demonstrate to you. Can you guys see? I hope you can see because I am not seeing what you can see. I cannot see myself. Anyway.
We're seeing you, Doc. We're seeing you with it in your hand.
Okay, you can see, thank you. All right, so to check the pH now, I don't have the urine bottle with me, but I believe it's the third one. So you just fold it to the one that is for pH, and then you apply that square to the inferior fornix you can use of the patient's eye, and you just check it against the container, and you should get a pH of 7 to 7.5. If you're getting a pH outside of that, continue to irrigate. All right, after you have achieved a pH of 7 to 7.5, you then refer the patient emergently to ophthalmologist or accident and emergency. Okay, so in these patients, remember when we had the checklist of things that you need to have in your setting, your GP setting, we had included anesthesia. So this anesthesia would be useful in this case because sometimes irrigating the eye, especially with so much fluid, is a bit uncomfortable for the patient, and so you can anesthetize the patient's eye before you begin irrigation. All right, so this patient now, I know it's not very interactive because you can't really speak to me live, but I hope you know what this, I'm gonna tell you the presentation, and I hope you guys can figure out what the person has. So this person came in with very severe pain to the right eye. This is the right eye here. I hope you can see my pointer. And severe pain with nausea, vomiting, and headache, right? They have had previous episodes before, but not as bad as this episode. And they came to, because they cannot stand the light. It's very uncomfortable for them, and the eye is very painful. So as you can see here on examination, it's a bit red, the conjunctiva. You can see the pupil comparison to this one is mid-dilated. So I hope you figure out by now this person has acute closed angle glaucoma. Generally, when the intraocular pressure is very high, we expect the cornea to be a bit hazy. So this cornea is quite clear because you can see very good iris detail here. All right, so this person should be referred emergently to the ophthalmologist. if topical intraocular pressure lowering agents are available, like say Combigon, you can give the person stat en route to the hospital or the ophthalmologist. Okay. All right, so this person has a very common presentation. So they may have come in because of watering, itching, and discomfort, maybe photophobia to one eye, and then it started happening in the other eye as well. As you can see, both eyes are injected, the left eye a bit more injected than the right eye. Okay, so this person actually has a viral conjunctivitis, or what we commonly call a pink eye. So you know you have different types of conjunctivitis, allergic, bacterial, viral conjunctivitis, and you can differentiate them based on the presentation, the history of the patient, as well as the examination findings. So this person so in terms of the discharge, a bacterial discharge would more be thicker, usually get it in one eye alone, usually it's more yellow and they notice a stickiness, right? In a viral conjunctivitis, it's more watery, and it probably starts in one eye, and they may have been itching it, and then it probably moved to the other eye, and they may have been around other people who have had the same symptoms. All right. In terms of allergic conjunctivitis, they may notice that it comes on seasonally or when the grass is cut, and both eyes are likely to be more mildly injected, usually more mildly injected, and they may also have a watery discharge. Okay. If you have a viral conjunctivitis, there's no need to use antibiotics. You can give them a topical lubricant like say Refresh or Cyster or Cysteine eye drops. These are also over the counter to help them to be more comfortable, but they don't need antibiotics, and they don't need referral to the ophthalmologist. But if you are concerned or you're not sure, just refer the patient. That's okay. All right, so this patient now has come in because of sudden onset of double vision. So as you can see here, look at the left eye, you can see it has a down and out position. So this person also, if you look closely at the pupil, you can see it's a bit dilated in comparison to the right eye. See, it's a bit dilated in comparison to this eye. And this person is also helping them to elevate this eyelid here. So they have a down and out position, dilation, as well as a ptosis. So this person has a third nerve palsy and should be referred immediately to A&E because something sinister like a posterior communicating artery aneurysm may have occurred. All right, this is another common presentation. They may come in because they notice this growth to the eye or this swelling to their eyelid, and it's not really painful, but it's been there for a while and it may have gone away and come back, but they don't like it, so they came to you. So this is not an emergency, it's a chalazion. You can refer them to the ophthalmologist because sometimes it requires surgical treatment to remove it, but in the interim, you can encourage them to do lid hygiene. So that involves a Q-tip and gently screen the lids with dilute Johnson & Johnson baby shampoo because it's no tear, so when it goes into the eye, if it goes into the eye, it won't burn. You can also encourage them to do warm compresses, so they can warm a rag and keep it on the eyelid for maybe 15 to 20 minutes, 2 times a day if they can. All right, and you can also give them tetracycline ointment because sometimes that can also help them. So you can do that in the interim while they wait for their routine appointment. All right, this person may have come in because they just noticed that they woke up and their eye had this color and they came in because they were concerned. So this is a subconjunctival hemorrhage. In isolation, we're not concerned. However, if you are concerned about something else apart from just this subconjunctival hemorrhage, then no problem, you can refer the patient. Okay, so they may be on anticoagulation, they may have a history of heavy lifting, coughing, maybe they have a recent cough or straining, constipation, all right, and they could have burst a blood vessel here. All right, so this patient may have had a history of contact lens wear and came in because of sudden redness and pain, immense pain to their eye. So as you can see here, there's a defect on the epithelium here. This person has a corneal also, requires very urgent referral to the ophthalmologist, okay? All right, this is another common presentation. So as you can see, there's a fleshy growth here that is encroaching upon the corneal, past the corneal limbus, going actually to the visual axis. So if this patient is dilated, it would actually encroach upon their visual axis. So this is a pterygium, also can be referred for surgical management. However, in the interim, you can encourage them, you can give them a lubricant, like, as we said, Refresh, Cyster, Cysteine eye drops to help them to be more comfortable. You can also encourage them to wear protective eyewear outside, especially in the sun. So UV protection, and also stay out of the dust, or wear protective goggles if they work in the dust. All right. Sometimes those things can aggravate this. And this is a very common condition, especially in our population because of the climate. All right, so this patient may have presented with, so this is the left eye, okay? You can see the optic nerve is on the left side, so this is the left eye of the patient. So this patient may have presented with sudden decrease in vision to their left eye, okay? Their left eye. And on examination, this is what you see. So they may also have diabetes, high blood pressure, they may have, all right? But if you see the patient presenting like this, you may be suspicious of an anterior ischemic optic neuropathy, possibly secondary to giant cell arteritis, and this person requires urgent referral to the ophthalmologist, okay? However, it is important to note that if they have decrease in vision to both eyes, or on routine examination, you notice this appearance of the disc in both eyes, then you refer them to accident and emergency, okay? Because we need to rule out any sinister cause that could result in bilateral disc swelling like this. Okay, this is a little baby or a little child, and you notice when you saw the baby for the checkup, you did a red reflex, or you shone a light into their eye, and you notice that the left eye, the red reflex appeared white. So this baby has leukocoria. It is important to refer these patients very urgently to the ophthalmologist, because something sinister like a retinoblastoma has to be ruled out immediately. So very important for young children, if they have a white reflex like this, to go to see the ophthalmologist as soon as possible. All right, so this one now, this person may have had a sudden decrease in vision to their left eye as well. And on examination, you see this. So you notice the entire fundus is white, and you notice a cherry red spot right here in the macula. So this person has had a central retinal artery occlusion, and ideally should be evaluated for a stroke, because they basically had a stroke in their eye. Okay, and this person can be referred directly to A&E or to the ophthalmologist. And en route, you can educate them to do ocular digital massage. So use 2 fingers, whether from one hand or from both hands, and gently massage the closed eye, right, in attempt to dislodge an embolus that could have caused this to occur. Also, you can encourage them to rebreathe from a brown paper bag, because it should encourage dilation. And really what you want to do is allow the eye to reperfuse as soon as possible to circulation to come back, because if there is no circulation for about 240 minutes or more, there is irreversible damage, okay? So the patient will not get back their vision. So it's important to recirculate blood in the eye as soon as possible, preferably under 90 minutes from the occlusion occurred. So remember, ocular digital massage, as well as rebreathing from a brown paper bag. Not until they pass out, just what is comfortable for them. So if they're rebreathing, ensure to tell them if they're breathing and they start to feel dizzy, to stop for a while, okay? This person, so this is the right eye now, because you see the optic nerve is on the right-hand side. This person may have also had sudden decrease in vision to this right eye. So this is a central retinal vein occlusion and can be referred to the ophthalmologist. All right, so this patient may have come in because of a 3-year gradual decrease in vision to their right eye. This is the right eye. And they notice the past 3 to 6 months, the vision has just worsened, right? So you see here, they have a pretty mature cataract here in the right eye. So this patient can be referred for surgical management. All right, this patient, so you can see here, they may have been hit to the eye, okay? Hit by a nail, hit by a fist, whatever sort of trauma. Sometimes it doesn't even have to be trauma, but commonly we get them because secondary to trauma. So you can notice here, this is in the anterior chamber, you can see blood. So this person has a high femur. So this person should be referred to the ophthalmologist as well. Then here you have a hypopion. This person should also be referred to the ophthalmologist. It could be an infective cause. Okay, so this patient now came in because they noticed that their left eye was swollen, they had fever, and they had pain when they moved their eye. So this patient has an orbital cellulitis, which would be confirmed on a CT scan. All right, so they should be referred to the hospital as well. Okay, this patient would have come to you because they noticed they're seeing a shadow, right, in their vision, and the shadow is likely to be inferior nasal in their right eye. Okay, so you notice there's a majority is a superior temporal retinal detachment. This is our retinal detachment will look like. Okay, so refer this patient very urgently to the ophthalmologist. Okay, eye referrals. So this is a little table showing you when people, basically what presentation people come in with and when they should be referred or be seen by the ophthalmologist. So emergency, these patients should go directly to A&E or emergency eye clinic. Anybody with sudden loss of vision, anybody with acute glaucoma, anybody with a perforating injury or intraocular foreign body, chemical burns. But remember, chemical burns, you have to manage from your practice before you refer them outside, right? Retinal detachment, corneal ulcer, sudden onset of diplopia or squint, temporal arthritis with visual symptoms, and those who should be referred the same day or less than 24 hours are those with a high femur, vitreous hemorrhage, orbital fracture, any sudden onset of ocular inflammation, any corneal foreign bodies or abrasions, urgent, like less than 2 weeks, anybody with any central visual loss, sinister floaters, flashing lights without a field effect, any chronic glaucoma with a pressure over 35 millimeters of mercury. So I know in your setting, you may not have the resources to check the intraocular pressure. So these patients, we can do is send them with a referral, and we would like to check the intraocular pressure before we let them know when we will see, in terms of which appointment they will get. All right. And those for routine referrals or routine visits are those with gradual loss of vision. So that could be because of a cataract, any chronic glaucoma, unless the pressure is over 35 millimeters of mercury, any chronic red eye conditions, painless diplopia or squint, if they have a chalazion or a styra cyst, and anybody with a ptosis. That's a long-standing ptosis. Okay. So in conclusion, ophthalmic complaints are often very unfamiliar territory for non-ophthalmologists. Most importantly is to recognize those which require immediate referral. With systematic evaluation and appropriate tools, most eye complaints can be accurately triaged in the GP setting. And if you are unsure, don't be afraid, just refer. But remember your visual acuity on your referrals. These are my references. Thank you.
Thank you, Doc. Perfect presentation. I'm pretty sure I've been seeing everyone saying great presentations.
Thank you very much, Dr. Yap, for that presentation and fundamentals of eye exam in history, and also the tips in terms of doing our referral appropriately. We're going to be thanking all our presenters in the first session, Dr. Fiedel, Dr. Leiberg, and Dr. Yap, for an excellent presentation. The next item on the program is a video from one of our sponsors, H2K. And Sam, are we ready for that video?
Yeah, we have the video, sir, but I'm not sure. Does Dr. Yap, would you like to take your questions before I run that video? Because we have a few questions. I'm not sure.
There was a segment for it, but sure, no problem.
All right, so let's take a few other questions so that it flows, and then we go into the presentation.
Okay.
I see the first one is, where can we source mydriatic agents? You're muted, Dr. Yap.
Oh, I am supposed to answer these questions.
Yes. Yeah. While you're doing that,
if my other colleagues are there, you could help me. Should I just type it?
Sure, you can type it, and what I'll do is I'll run one of your polls that you had set up before we go into the presentation. So everyone, here's a poll from Dr. Yap. And we'll see We'll run it for about 15 seconds and see what the answers are like. Run it for 10 more seconds. All right. So that's the result, Doc. I think most persons got it right, yeah?
Yes, good job, guys.
All right. And then one more here. All right. That's the result there.
Good job, guys.
And the last one. Ten more seconds. All right, there you go.
Good job, guys.
Right, so I think your presentation was very well received. Thank you very much. I know you'll answer the questions in the Q&A. So as Dr. Gordon says, we're gonna go over now to a presentation from one of our sponsors. Here we go.
Good day, this is Amoy Rickman from Health 2000 Canada, otherwise known as H2K. We are a generic pharmaceutical company proudly serving you since the year 2000. We offer a wide range of products to treat many therapeutic forms. Total Neem Cream is locally recognized for the diabetic foot. Used twice daily, it reduces the formation of ulcers. Total Neem Cream is effective on cuts and scratches, insect bites, skin inflammation, dry cracked skin, sore nipples for the nursing mother, and so on. So when you need a herbal alternative, use H2K Total Neem Cream, your personal companion for wounds and skin infections. H2K azithromycin 500 mg tablets is quite fast acting within 2 to 3 hours. In addition to H2K azithromycin tablets, we also offer H2K SCSI, azithromycin 200 mg per 5 ml oral suspension, useful in elder care. SCSI also has a surprisingly good taste, a nice menthol mint flavor. Our broad spectrum antibiotic is H2K co-amoxiclav. Another antibiotic is our H2K ciprofloxacin 500 mg tablet. H2K Dawacough, an excellent expectorant and bronchodilator, contains salbutamol, bromhexine, guaifenesin, and menthol. Tastes great. So when you are treating wet cough, dry cough, any cough, use Dawacough. Dawa means do away. KOF is cough. Dawacough. H2K meloxicam 15 mg tablets, just 30 minutes for reduction in pain intensity for the long-term treatment of rheumatoid arthritis, short-term treatment of osteoarthritis, acute sciatica, ankylosing spondylosis, and acute lumbago. H2K BTAD, betamethasone dipropionate cream, or anti-allergic topical cream. Get quick relief with BTAD. H2K Scaderm or SK-Derm combines betamethasone, clotrimazole, and gentamicin for the 3-in-1 effect. H2K tada! Tadalafil 20 mg tablets for erectile dysfunction. H2K Migra sildenafil 100 mg tablets. Both Tada and Migra cost just $300 per tablet. We have several over-the-counter products that we hope will be quite useful. H2K Wormizole albendazole 400 mg suspension, great tasting and eliminates most common intestinal worms. H2K Glucolite is the best tasting orange flavor oral rehydration salts in Jamaica. H2K Go Gel keeps you going. Do you eat at least 3 to 5 servings of fresh fruits and vegetables per day? No? Well, maybe you need to supplement. Consider Vitamax, one of the most complete multivitamin and mineral syrup on the market today. Vitamax is beneficial from 1 year to adults. Boost your immunity and performance with H2K Vitamax. H2K Naturella 5-in-1 cream is water-based, so it does not clog your pores, and it also does not bleach your skin as it does not contain hydroquinone. It is dermatologist recommended. H2K Silvacant is active against a large number of bacteria and fungi. Or affordable products are available in pharmacies island-wide. Please support us by writing H2K before the drug name on your prescription. Please follow us on Instagram and Facebook. Thank you and be safe.
Over to you, Dr. Gordon.
Okay, thanks, H2K. Thanks for support as usual. And Sam, are we going to go into the next sponsor presentation, R.A. Williams, or are we going in straight into the session with ethics?
We can go into R.A. Williams as they're online. So if you're ready, we can do that.
Yes, I think that was what was on the agenda. So we could go with the R.A. Williams session.
All right, so Kim Roy, are you hearing me?
Yes, Dr. Gordon.
Hi, Kimoy. Welcome, Kimoy.
Good morning, Dr. Gordon. Thanks for having me.
Okay.
I must say the presentations thus far have been quite informative. So thanks again for approaching us and actually allowing us to sponsor this session. Yeah. So Sam, is it possible for me to go ahead and share my screen now? Is everyone hearing me?
Yes, I'm hearing you.
Oh,
we're hearing you. You can go ahead.
Oh, I was asking, I can go ahead and share my screen?
Yes, go ahead.
All right. All right, so good morning, everyone. I'm Kimra Williamson, Country Manager for Arista Pharma Limited. Today, we just want to bring you a short presentation on a few of our products to tie into what both Dr. Yap and Dr. Liburd would have discussed earlier. So in terms of Arista Pharma, we believe, of course, that quality is actually a journey and not just a destination. So we are one of the top 10 pharmaceutical companies in Bangladesh. The company has actually been in operation since 1986 with the honest promise of providing quality medications to the countrymen. Now, with their success in Bangladesh, we've actually started to branch out into other countries with 34 countries on 5 different continents actually carrying the Arista Pharma line of products. We have a robust product range with over 200 brands and over 400 dosages. And of course, worldwide, we have a staff complement of over 6,000 employees. Locally, we are distributed by Arway Williams Distributors, as Dr. Gordon had mentioned. So before we get into the products, just want to highlight the fact that, at Arista Pharma, quality is one of the biggest parameters that we pride ourselves on. So again, we believe quality is a journey and not a goal. So therefore, we are continuously improving our quality efforts to ensure that we can serve our patients better. And, this led to the motto of the company being quality, the only unit we count. Now, just to go into, the presentation for today, to kind of tie it back into a few of the products, we have a short case study here. I hope everyone was taking note of what Dr. Yap was saying. So you will see that in terms of what we're offering, it's basic information versus the additional info that you would require on your examination. However, we just want to give you an idea of one of the cases that you might see, or one indication that you might see, and the use of one of our possible products. So Paul comes to you, he's 39 years old, he's a construction worker, and he has no previous complaints of ocular injury or discomfort. Now, his complaint today is that while carrying out his duty, he was struck in the right eye by debris. And since then, he's reporting that he's been feeling pain of moderate intensity along with general discomfort around the eye. He, however, does not report any visual disturbances. Now, based on the recommendation of a friend, he has actually been using ice to ease the swelling, but hasn't seen any significant improvements. Now, on your assessment, what you would have seen is that there's some amount of inflammation around the eye. The eye is slightly red in appearance, but no visible signs of lacerations nor avulsion. We tried to get a good enough representation of what you're seeing here. Of course, the eye would be a little bit more red than this. Now, in terms of your diagnosis, of course, Paul would be suffering from trauma to the eye with some degree of uveitis. Now, just to tie back to the previous presentations, for cases like this, whenever you're uncertain, we still recommend that you should refer to the ophthalmologist to ensure that you're getting the best treatment for the patient. However, for mild cases of uveitis, whenever you have trauma to the eye, our recommendation is 1 drop of Nevan instilled in the affected eye 3 times per day for a period of about 7 days. Now, again, to tie back into the previous presentations, the recommendation as well is that a person like Paul should definitely be using protective gear at work. Now, Nevan works so well in the general practice setting because for a lot of the times, I know that some doctors have their reservations about using a steroid. Now, Nevan as an NSAID has a couple unique benefits that we want to highlight very quickly. So, of course, Nevan, active ingredient Nepafenac, is the first and only non-steroidal anti-inflammatory prodrug that has actually been approved for ophthalmic use. So it provides a novel drug delivery mechanism, and we'll go into that shortly. It has analgesic and anti-inflammatory effect, which reduces pain and inflammation. So for a patient like Paul, Nevan would actually be one of your ideal go-to medications. Now, why are we saying that this drug has a novel mechanism? So unlike other NSAIDs, which are acidic in nature, Nevan tends to be a more neutral option in terms of irritation to the eye. Now, Nevan starts out as the active ingredient, Nepafenac. However, once it's instilled after passing the cornea, it is actually converted to the active drug, which is Amphenac, which is the more potent form. So this is how you will actually be getting your effectiveness. So it will come from Amphonac and not Nepafenac. Now, the benefits of Nivan is that it can reduce ocular inflammation and macular edema. It allows for visual rehabilitation, and it reduces the incidence of post-operative conjunctival hyperemia, and it's little to no ocular discomfort. One of the main issues with NSAIDs in the past, and I'm sure many of you would also have this experience, is that patients do complain about some amount of burning or stinging. Now with Nivan, the incidence of these complaints should be less. Now at the same time, it offers 5 times greater affinity for COX-2 enzymes versus bromfenac, and it's 51 times more potent at inhibiting COX-2 enzymes versus ketorolac, which is another option that we have. Now, looking at more conventional NSAIDs, they are actually 4 times more potent at reducing prostaglandin synthesis versus a diclofenac. And just a point of note, because we do get the feedback quite often from our pharmacists that the prescriptions still are coming out with diclofenac. However, the diclofenac, there has been no diclofenac ophthalmic brand for a few years now. So what we're suggesting is for the cases where you would use a diclofenac drop, the Nivan would actually be a very suitable replacement. In terms of cost, we are working out to be half of what the brand is. So it works out to be less than $3,000 per bottle. Now, in terms of just the highlights for the Nivan, it ensures that you're getting excellent penetration into the ocular tissues. It also has better corneal permeability than diclofenac and ketorolac, and you're getting fast penetration, which increases the onset of action and the benefits to the patients. Now, as Dr. Yap had mentioned, for some of your cases, it would be ideal, especially for foreign body sensation, to use a lubricant. Now, from Arista Pharma, we have Cystear, which is our combination of polyethylene and propylene glycol, sorry about that, the unique lubricant for dry eye and ocular discomfort. So we'll talk about dry eye briefly, and also, some of the benefits that the patients who are experiencing foreign body sensation or ocular discomfort would get. So 75% of people who work on computers for more than 3 hours a day are actually affected by computer vision syndrome. So we're not sure if everyone is aware of that. And especially now with the work from home orders, we are anticipating that we're going to be seeing an increase in these type of cases presenting in your offices. Now, many of the complaints of computer vision syndrome will mirror that of dry eye. So in addition to foreign body sensation, dry eyes, we also need to be looking out for computer vision syndrome, because everyone right now, just like we are, would be glued to a screen, whether it's a tablet, a TV, or a laptop. So we have to be mindful of this. Now, some of the symptoms will include painful stinging sensations, a burning sensation, consistent tearing, or the patients might complain again of that foreign body sensation, so having that gritty eye feeling. Now, why Cystear? Cystear has 2 unique polymers in one outstanding formula. So the polyethylene glycol ensures that you're getting excellent lubrication on the eye surface, and it's used as a protectant agent against further irritation. Propylene glycol is also used to offer additional lubrication to the eye. Now we'll go into why these 2 polymers make this one outstanding formulation shortly. Now, the benefits that Cystear has over all other eye preparations is that with the use of borate combining with our 2 polymers, you're forming a protective gel matrix over the ocular surface. Now, this facilitates regeneration of corneal epithelial cells. So in terms of overall benefits, the patients will feel improvements much longer than what they would experience with some of your other conventional lubricants. Now, compared to your CMC containing eye drops, Cystear would actually offer 6 times more lubrication. So when you're looking at it, cost-wise, we work out to be the same or slightly over by maybe about $100 or so versus your typical lubricant. However, for that extra $100, the patients are getting 6 times more lubrication, which means that in terms of efficacy, it will be greater for the patients on Cystear. And at the same time, in terms of the long-term benefit, you will see patients responding better to Cystear than many of the other lubricants. Now, just to quickly highlight some of our other products. For allergic conjunctivitis, we have our olpadine, which is our olopatadine 0.1%, and our staphane, which is our ketotifen 0.025%. So depending on the severity and the type of patient that you're seeing, we have 2 options here for allergic conjunctivitis. Now, for bacterial conjunctivitis, as Dr. Yap had mentioned, you can use a steroid along with an antibiotic. So we have our Aristabet N, which is our neomycin, and beclomethasone that can be utilized. Now, based on everything, I know everyone is wearing a mask, but we do anticipate that the allergy season, which should be upon us right now, you'll start seeing increasing cases. So for allergic rhinitis, we have our Flutica, which is our fluticasone furoate, which is the only brand alternative to the brand on the market right now. In terms of savings to the patients, if you're looking without a health card, the patients are saving over $1,500, which again can go to your oral antihistamines or any other agents that you would be using in conjunction to the nasal spray. And for your patients who would actually be using a health card, it works out to be less than $500 for the bottle of Flutica. So in terms of savings, we are pushing that benefit for the patient, but at the same time, they're getting significant benefits in terms of the efficacy and the quality of the products. Now, for asthma, we have our 2 inhalers. We have our Aeroflow, which is our salmeterol fluticasone combination, which would be more for your maintenance cases. However, we also have our Sulflow, which is our salbutamol for your rescue cases. So for those emergency cases that you would need salbutamol, we have our Sulflow. In terms of cost to the patient, after NHF or Sulflow works out to be about $300 or less, depending on the pharmacy. And with our Aeroflow, it should be fully covered by the NHF. So again, at Arista Pharma, we are pushing quality for the patients. We want the patients to get better faster, but at the same time, we are ensuring that every medication that is on the market, we're ensuring that the patients are getting it at a very affordable price. So that is it for our presentation today. Thanks again for having us. If you have any questions, I'm quite available. You can either send me in the question and answer, or you can put it in the chat and I'll gladly respond. All right. Thanks again, everyone.
Thank you, Camroy. Very lovely presentation. I see we're following the presentation quite well. You got all the points right.
Yeah, there were 2 very good presentations, I must say.
Okay, well, thanks for your support. Our next presenter coming up will be Dr. Jordan, and he'll be speaking about the red eye.
Actually, Doc, sorry to interrupt. We're going to have Indus go ahead and do their presentation.
All right. Okay, Sam. Okay, go ahead, Indus.
Good morning. Good morning, Dr. Gordon, and good morning, all participants.
Good morning.
Mr. Sam, could I share the screen?
Sure. Go ahead and share your screen.
Yes.
Remember, click on share screen. You'll see screen highlighted in blue at the top left.
Yes.
Then you click on sound at the bottom left and then click on the share button.
Sure. Is it? I'm sharing now.
Coming
You would
up.
be able to see.
Sure,
Able
you
to
should
see
be
it.
able to open your PowerPoint now. I'm seeing where you're in a folder on your desktop. So click on the PowerPoint, double click on it to open it.
It says now you're sharing.
You are sharing, but you're not sharing the PowerPoint. Did you open the PowerPoint?
Yes.
Let me take control of your computer here.
You see it now?
Yeah, seeing it now. Indus Life Sciences, enriching
Yeah,
lives through better
exactly.
products.
Exactly. Exactly. Can I go
All
ahead
right.
now?
Yeah, please.
Yeah. Good morning, everyone, once again, and hope all are doing good. I'm Daya from Indus Life Sciences. So this is the first time I'm coming across ophthalmologist. We have been working with other specialists like general practitioners, surgeons, ENT, orthopedician, gynecologists, and family physicians. So this is the first time I'm coming board on ophthalmic, webinar or a meeting. So I'm very eager to work with ophthalmologists soon. So from Indus Life Sciences, we have a couple of brands to share. We are here in for the doctors who are not aware of Indus. We are here for the last more than 5 years in Caribbean, and the company is operating in more than 53 countries across the globe. And for us, Jamaica is the headquarter for Caribbean. From here, we are operating in all Caribbean, English-speaking Caribbean specifically, like Guyana, Trinidad, Barbados, as well as Cayman, Bahamas, and other countries. Of course, we are also present in some of the Central American countries like Honduras, as well as we are in Haiti also currently. So just to share a couple of the brands that we have it, one of our drug is a supplement, which is ideal for this time. As we all talk about COVID, the pandemic, and we all talk about immunity, and we know pretty well till the vaccines is available, the only thing that can help us to fight against the invisible enemy is our immunity. If the immunity is good, we are protected from this invisible enemy. And when we talk about immunity, obviously we can't omit vitamin D3 or especially vitamin C, which is good for cold and flu, and zinc, we all know that is good for immunity. And this is the first supplement in Caribbean offers all the three plus all other vitamins like B1, B2, B6, B12, vitamin E, vitamin A also. Plus, it is the first supplement we call as a complete formula. The reason it offers all amino acids and active form for protein synthesis. So this is a complete supplement, as you could see here, starting from arginine, histidine, leucine, isoleucine, lysine, phenylalanine, threonine, as well as valine, tryptophan, plus all vitamins are there, including vitamin D3, vitamin C, and zinc, which is very ideal for this pandemic time. And this is ideal for every age group, right from pediatric to geriatric. When I say pediatric, we normally recommend it above 18 years, 18 months, because less than 18 months, mother's milk is sufficient. From 18 months upward, it could be given 2.5 ml twice a day for kids. For adults, it is 5 ml twice a day. For somebody who is undergoing chronic, medication or treatment, we can step up the dose up to 15 ml, like post-surgery or person undergoing chemotherapy or C13 patients, immunocompromised people, we can step up the dose. Otherwise, it's 5 ml even for those who regularly go for gym. Is very ideal for them. And that's our amino pep. As we all know, healthy family represents healthy society. Healthy society represents healthy nation. So to build a healthy nation, you can consider amino pep. We coined the brand name amino pep to give a pep to your step. That's why it calls amino pep. Gives a pep to the step. So we have another drug, which is a topical drug for pain management, as pain is part of the life. This is we call a SWAT team called as Capsitop. This is a over the counter product. The specialty of this pain rub, normally when we talk about pain rub, we normally think of diclofenac. I'm not bashing it. It's a wonderful drug, but sometimes some pain needs more. Diclofenac alone will not be sufficient. So we have this SWAT team, which has got diclofenac plus methyl salicylate, which also inhibits the pain mediators, and also it has capsaicin. which is another drug which also inhibits pain. The capsaicin is nothing but out of pepper and approved by US FDA for neuropathic pain also. So this is the first composition which offers three different active drugs work in different mechanism, and thereby it offers complete reduction of pain. And it's ideal for every pain, especially knee pain, wrist pain, shoulder pain, neck pain, back pain, arthritis pain, diabetic foot and conditions. The only indication which may not be useful is heart pain. Rest all other pain it could be considered. And being it has capsaicin on it, the only recommendation is that not to massage aggressively. Just a little spread is sufficient, and of course we have to wash the hands thoroughly after applying it. It's a 30-gram tube and is available around $600 to $650 in all pharmacies across the island. By the way, aminopep is also over the counter. It's available in all the pharmacies across the island. Aminopep is available. And as I said, we will be meeting soon ophthalmologists. That we are a company stepping into ophthalmic specialty. So we are going to help the vision of Jamaica better along with other companies that is currently in. So this is a range that we are introducing very soon. So soon our medical rep will be coming down to meet you and detail our ophthalmic products. For glaucoma and ocular hypertension from Indus Life Sciences, we are introducing timolol maleate, as well as dorzolamide, as well as bromodin, as well as dorzolamide with hydrochloride and timolol combination will be there soon. Most probably by first month of the new year 2021, that is January, our brands will be available here. They are registered with Ministry of Health, and soon you will see the drugs in the pharmacies, and our medrep will be personally visiting you and detailing the products to you. And also we are introducing for dry eye, we have the Carmelo sodium 0.5 as well as 1% will be available. And the other one for infected eyes, we have the antibiotic ciprofloxacin drops, as well as tobramycin eye drops, as well as tobramycin plus dexamethasone eye drops will be available in the pharmacies. And our medrep will be soon at your doorstep to introduce these brands to you. When we meet you in person, we'll share more information about our product as well as price and everything. Till the time, stay safe. Thank you very much. Hello? Thank you very much, Mr. Samuel.
Amen. Thank you very much. Dr. Gordon, over to you, sir.
Thank you very much, Indus Life Sciences. Thank you for your consistent support of AGPJ. And we look forward to continually working together mutually. Sam, I'm not sure who we have up next. Is it Dr. Jordan or Dr. Delahaye?
We have Dr. Jordan. Dr. Delahaye isn't on yet. So we'll move Dr. Delahaye over to the second session with Dr. Swaby.
Okay, thanks, Sam. Our next presenter is Dr. Jordan, and he's presenting on the red eye. Dr. Jordan is a Cornell College alumnus. He's a final year DM resident at UWI. He graduated with his MBBS in 2010. And we welcome Dr. Jordan to speak to us on the red eye. Dr. Jordan, welcome to you, sir.
Thank you very much, Dr. Gordon. All right, so can everyone see my presentation?
Yes, sir, coming in clearly.
Lovely. Okay, so I'm Dr. Jordan. I'm going to be presenting on management of the red eye. So before we actually start this presentation, I'm going to give you guys all a quiz, and you can blame Dr. Gordon because he really wanted a quiz. Quite a simple quiz. So I'm not sure if you guys are seeing the quiz yet, but I'm showing you this picture, and I want to know which of the following is this. So is this a subconjunctival hemorrhage, a hypopion, a hyphema, or is this acute angle closure?
All right, so we're getting a lot of responses. We're gonna allow it for 20 seconds and then close it off and share the results with you. 5, 4, 3, 2, 1. These are the results.
Whoa, 87%. So do you guys actually really need this lecture? Okay, so next question. There are no pictures this time. So which of the following signs or symptoms, if present, would you consider to be, well, let's say most urgent or a red flag? So itching, corneal opacification, watery eyes, or discharge?
Do I get to vote?
Sure.
And we end in 5, 4, 3, 2, 1.
Okay, 92%. All right, so we're getting even higher, maybe 100% next time. All right, so now, finally, question 3. So a patient presents with redness, grittiness, and watery discharge to both eyes. They have normal vision, their cornea is clear. Which of the following is the most appropriate management?
Five, 4, 3, 2, 1.
Lovely. Okay, wonderful. All right, so with this being our baseline and you guys already knowing a whole lot of ophthalmology, we'll continue. So as you probably know, the red eye has a lot of possible causes. This isn't even half of them, and it's one of the most common things that presents to the ophthalmologist. I'm also quite sure it's one of the most common things that presents to the general practitioner that's eye related. So we'll talk about the red eye. So first of all, what's the cause? So there are really two ways. So one way is that you get dilation of the blood vessels on the surface of the eye. This is what you call your bloodshot eye, and it may be due to inflammation or to congestion. And then the other option is that you get bleeding from the eye surface vessels, which is the subconjunctival hemorrhage, which was it 90% of you identified? So as you see here, we have vasodilation being caused by either inflammation or vascular congestion. Some of the things that could cause inflammation are infections, autoimmune disease, allergy, irritants, and trauma. While vascular congestion, one of the things is acute angle closure glaucoma. There are some other causes, but we're not really going to go into them. Now, another thing to look at is the pattern of the eye redness. So you guys went through the examination of the eye. So when you're examining a red eye, we're looking at where the redness is. So is it generalized? Is it perilimbal or circumcorneal, or is it localized to a certain area, which you could get in things like an episcleritis? So I know I've shown you these cartoony eyes, but this is what it looks like in real life on an actual eye. So on the left, we have our generalized conjunctival injection. We have our circumcorneal in the top right, and then localized to the nasal side in the bottom right hand. Now, when you're examining these patients with red eyes, there's some red flags that you should look out for. So first one is decreased visual acuity. The second is severe pain, also photophobia, trauma, and within trauma, I'm going to include eye surgery and chemical injury, not just mechanical trauma. Also corneal opacification and an absent or sluggish pupillary response. Now, we're going to go through a couple cases to see if we can identify these red flags. So this first one, I patterned off a classmate of mine who came to see me complaining that he was having redness to both of his eyes for the past few days, about 3. And it first involved the right eye and then the left eye. And he was having this watery discharge and gritty sensation, but vision was normal. There's no staining with the fluorescein, and his pupillary reaction was normal. So this is something you'll see quite commonly. And so far, I've given you no red flags, but this is the often seen viral conjunctivitis, known colloquially as pink eye. So these patients may have had a recent viral illness. And of course, in this case, and in this time, you'd want to know if this is coronavirus, because coronavirus can cause a viral conjunctivitis. But these patients will have a watery discharge typically. It's not purulent. This is a self-limiting disease, normally lasts probably about 7 to 10 days. So how are we going to treat them? So first of all, hygiene is very important. So in the case of my classmate, I gave him sick leave because I didn't want him spreading this around the community. But also, you should avoid touching and rubbing the eyes and frequent hand washing. Of course, we want to treat the symptoms. So things like artificial tears and cold compresses can help. Antibiotics are not necessary. It's actually something that's debatable because you can get a secondary bacterial infection, but most people will not need antibiotics in this case. Now, this is a patient I saw in the clinic. You can see how mucky this eye is. So this is our bacterial conjunctivitis now. There's a copious purulent discharge. You can have the eyelids glued together by the discharge when you wake up. The vision may be temporarily blurred because of the discharge, but once the discharge is wiped away, the vision should essentially be normal. So once again, hygiene measures that we said before, so frequent hand washing, avoid touching the eyes, that sort of thing. And we're going to treat them symptomatically as well. But in this case, antibiotics help to speed up the recovery. So there are a lot of broad spectrum antibiotic eye drops and ointments available in Jamaica. Really, it comes down to things like cost and availability. So chloramphenicol is widely available in Jamaica. It's low cost, but there are many other options. I've listed a couple others like fusidic acid, tobramycin, chloramphenicol. Oh, I should point out, tell the patients not to put random things in their eyes like urine and breast milk because they will not help. So now, allergic conjunctivitis is another conjunctivitis you will see quite commonly, especially in children. But these patients will have a lot of itching. This is the main complaint. I've had it myself. This is often associated with atopy. So, you know, you're asthmatic, you're a person with eczema, and they'll present with a clear, stringy discharge. And the treatment is usually antihistamines, mast cell stabilizers. If this is not responding to treatment, please send it to an ophthalmologist because we really don't want you to be using steroids without being absolutely sure what you're treating. So here's the second case. This is also something you'll see very often in your practice, I'm sure. So this is a 55-year-old postmenopausal woman. She's complaining of having intermittent redness, burning, grittiness, and watering to both of her eyes. She also finds that when she's watching TV, she gets temporary blurred vision and she has to blink quite often. But you check her visual acuity with your Snelling chart that you bought because Dr. Yap told you so. And she's 20/20. She also has mild generalized conjunctival injection, but otherwise you don't see anything really. So you don't really see any red flags in this case. And this, of course, is your ever-present dry eye. It's one of the most common medical problems because 7.4 to 33.7% of people may have this, depending on exactly how you define it. But these patients have a breakdown of the tear film, and it's commonly associated with decreased hormones associated with aging. So your elderly population will be the ones mostly presenting with this. There's an association with eyelid inflammation or blepharitis, also infrequent blinking, so things like prolonged computer use or watching the TV or playing video games maybe. If you have a dusty, windy, hot environment, this increases evaporation of tears, so the eyes become dry, and contact lens use as well. So these patients we treat with our artificial tears and possibly lubricating ointments in the first instance. Also, if they have an associated eyelid inflammation or blepharitis, then warm compresses and eyelid scrubs. If it's not responding to these treatments, then there's more that we can do. Please send to an ophthalmologist if it is not responding well to artificial tears. So now, you see here on the top, a pingueculum, and at the bottom, pterygium. So these are associated with dryness and exposure to ultraviolet light. And sometimes they may become inflamed, so the eye will be red, and artificial tears may help. In the case of a pterygium, you can refer to an ophthalmologist for further treatment, including possible surgical removal of the pterygium. So now, our third case. So this is a common thing. Farm worker, 40 years old, not wearing anything but working out in the field. This one was chopping a tree branch and think something hit him in the eye. But for the past couple of days, he's been having decreased vision, redness, gritty sensation to the right eye, and he has noticed a white spot on the black part of his eye. So you look at him, and here in the picture, you can see a quite prominent white area on his cornea. So this patient has a couple of red flags. I'm sure you've identified them. So he's presented with decreased vision, and he has a history of trauma in this case. This may not always be the case for this, but also corneal opacity. So this is a corneal ulcer. So it could be bacterial, fungal, viral, or mixed etiology. Please refer this patient urgently to an ophthalmologist. We'll probably do a swab or scraping of the cornea, and we'll prescribe antibiotics. Now, in this case, please, whatever you do not give steroids. I've seen a couple cases of patients like this who've been given steroids and it doesn't end well. I'll show you a couple pictures of what can happen. So what you get is a possible corneal melt. It's really bad. These patients lose their eyes. So do not give steroids. If a patient presents with a red eye and you don't know what it is, the last thing you should do is give steroids. So let's talk about iritis or anterior uveitis. So it's another relatively common thing. So you get inflammation of the front parts of the uvea, which is the iris. And these patients present with pain, redness, and photophobia is a prominent symptom here often. They may have blurred vision, and they'll often present with ciliary flush, which you guys know from the patterns. So circumcorneal injection, and this can be acute, recurrent, or chronic. These patients, you can refer to an ophthalmologist. They'll need steroids, steroid eye drops usually. Sometimes we give dilating drops for comfort. Some of these patients may also have an underlying systemic problem, such as rheumatoid arthritis. Now, here you can see a picture of a hypopion. So you can see it looks kind of like a hyphema would. You have a fluid level in the anterior chamber of the eye, but it is yellow, or well, whitish yellow. It's pus. That's what it is. So it's a hypopion. You can get this, for instance, in endophthalmitis, but anything that gives you a lot of inflammation in the front of the eye. So endophthalmitis is a purulent infection of the intraocular fluids. How does it get infected? So either it goes straight through the eye, so either eye surgery, through the wound, trauma to the eye. Sometimes if you have a corneal ulcer, you can get what we call an exogenous of endophthalmitis. And then another way is by hematogenous spread if there's an infection elsewhere. So these patients require an urgent same-day referral to an ophthalmologist. So you can see the red flag already. So if they've had surgery, that's a red flag. If they've had trauma, that's a red flag. They're going to have decreased vision, that's a red flag. If they have a corneal ulcer, you've already seen that they'll have a corneal opacity, that's another red flag. So 100% send to an ophthalmologist urgently. My fourth case now. So this is another patient complaining of a sudden onset of severe pain and decreased vision to their left eye. They're also seeing colored halos around lights. They also have a headache and they've had 2 episodes of vomiting. You look at them, you see in the picture here, so their cornea is hazy and you can see that their pupil is mid-dilated. And when you shine your ophthalmoscope light on it, it's not really responding the way you'd expect it to. So once again, we have a few red flags here. We have the decrease in vision, we have severe pain, we have corneal opacity in that the cornea is hazy, and also a sluggish pupil. This is your typical presentation of an acute angle closure glaucoma, which occurs when the iridocorneal angle is closed, as you can see in the picture. These patients will have a shallow anterior chamber. They also get a very high intraocular pressure. So that is why they end up getting a headache, nausea, vomiting. That this is from their pressure being somewhere in the 40s, 50s, or 60s, when it should really be in the teens, maybe towards 20, right? They also get corneal edema because this high pressure pushes fluid into the cornea, and they have a mid-dilated pupil. And the corneal edema causes them to have the blurred vision and to see colored halos around lights. Once again, urgent same-day referral to an ophthalmologist. This shouldn't wait. We want to do things like giving them systemic acetazolamide, which decreases the amount of aqueous that is produced to lower the intraocular pressure. Pilocarpine also helps to pull the iris away from the angle, and the definitive treatment is usually to make a hole in the iris, what we call an iridotomy. You already had a lecture on trauma. In general, trauma patients need to see an ophthalmologist because there can be lots of issues in the eye that you may not see. But in particular, on the left, you can see this is a high femur. These patients can have a high intraocular pressure as well. They'll have decreased vision, possibly because of the blood in their anterior chamber. On the other side, you see this is a very prominent subconjunctival hemorrhage. And a word on subconjunctival hemorrhage. Not all of them need to see an ophthalmologist. In the setting of trauma, yes. And in this case, you cannot see the extent of it because it's quite a massive subconjunctival hemorrhage. And in the setting of trauma, that's its own red flag because it could mean that there's a rupture of the eye. But I mean, there are lots of other causes, especially rubbing the eye, a Valsalva maneuver. So patients who probably cough or whatever, or vomit may have a subconjunctival hemorrhage with nothing else really, or patients with hypertension. So if a patient presents to you with subconjunctival hemorrhage, first thing, check their blood pressure. So, in summary, the differential diagnosis for a red eye is many and varied. I haven't touched the tip of the iceberg here, but I've tried to do the most common things and the most urgent things. So we've looked at our red flags already, so I hope you remember them. Decreased vision, severe pain, photophobia, which is sensitivity to light, trauma, corneal opacity, and an unreactive pupil. So some of the most common things are dry eye syndrome and conjunctivitis. You've seen the different types. Patients with things like a suspected corneal ulcer, iritis, endophthalmitis, or acute glaucoma require urgent referral to an ophthalmologist. And as I said, steroid eye drops can be very dangerous if used inappropriately. So if you don't know what it is, please don't give a steroid. It's the worst thing you could possibly do. So thanks for listening to me. I know you guys did really great on the pre-quiz, but you should do even better on the post-quiz. So
should we run it now, Doc?
Sure. So this is another picture now. I decided to mix it up a little bit. So question 1. So this picture on screen shows which of the following. So is this a subconjunctival hemorrhage, a hypopion, a high femur, or is this acute angle closure?
I think they picked up that it was a trick question. The answers seem different. We'll close in 5, 4, 3, 2, 1. Here are the results.
Excellent. So the majority of you picked up that this is not the same picture. This is actually a high femur. All right.
Perfect. The next question. Oops, sorry. Relaunching. There we go.
Okay, so which of the following signs or symptoms, if present, would you consider to be urgent or a red flag?
All right, high participation here. And we end in 5, 4, 3, 2, 1.
Okay, so even higher, almost 100. We're getting there. And now, finally, question 3.
There we go.
All right. So this is the same question I gave you before. So patient presents with redness, grittiness, watery discharge to both eyes. Vision is normal, cornea is clear. What's the most appropriate management?
5, 4, 3, 2, 1.
Okay, so I love that the majority of you said artificial tears. Remember, don't give steroids if you're not sure what it is. All right, so that's essentially my presentation. So these are my references, and thanks very much for listening.
Dr. Gordon and Dr. Jordan.
Dr.
Thank you
Jordan.
both. Just to let you know, Dr. Gordon, there are some questions in the Q&A if you'd like to do that, or if you'd hand over to the next session.
No, we could do the Q&A. One thing I'd like to ask Dr. Jordan, could you say when do you use steroid when you see a red eye? When is steroid appropriate?
When is steroid appropriate? I mean, honestly, I think for the most part in primary care, steroids don't need to be used a lot because most of the things that would require a steroid would also require an ophthalmologist. So things like a uveitis have to get steroids. A chemical eye injury, steroids is what we use to treat the inflammation. In very severe allergic conjunctivitis, like a very inflamed pterygium, we may use a steroid, but in most of those cases, I mean, like in the setting of a trauma, once again, where you may have an anterior uveitis from that, we would give a steroid usually, but all of those patients need to see an ophthalmologist anyway. So for the most part, you don't need to give steroids. I think. I'm not sure if, I think Dr. Calder's in the chat. I don't know if he has a different opinion.
What if you see a patient who gave a history of trauma to the eye like 5 days before and they were okay, and then a couple days after they start having photophobia and little pain in the eye? Would you want to recommend a steroid in that situation where they have a probably mild uveitis?
I mean, once again, they need to see an ophthalmologist as well.
Okay.
That sounds like a patient that
But
would
then it's
have
not so easy
a
to see an
traumatic anterior
ophthalmologist.
uveitis
Yeah,
though.
yeah.
So the treatment would be a steroid.
Okay, all right, okay, thanks. All right, questions in the Q&A, Sam?
Sure. So the first one was, above what blood pressure should we refrain from dilating the eye?
Honestly, I don't think there's a straight cut off for that. Usually it's really the phenylephrine component that we're worried about, because that can cause the pressure to go up even further.
Okay. From Dr. Arnold Brown Morgan, which bacterial conjunctivitis where periorbital swelling is significant, could we also add a short course of oral antibiotics? Would this be beneficial?
I mean, it could be, but for the most part, cases of bacterial conjunctivitis would respond to a topical antibiotic.
She says, sorry, she meant the difference in signs between vitreous and retinal detachment.
Oh, that's from a question I had answered via text earlier
from
on.
before.
But let's see. Difference between a vitreous and a retinal detachment. I mean, that's something you'd have to see on dilation, and look at the fundus to see if the retina is detached. I wish I could show you a picture of a retinal detachment, but both of them need to see an ophthalmologist, because if you have a vitreous detachment, you're going to have the same kind of signs, the flashing lights and the floaters, and usually we need to rule out a retinal tear or detachment anyway.
Right.
So send all of them.
Fair enough. What do you recommend for a very inflamed pterygium?
Where is that? What do we recommend for a very inflamed pterygium? Okay, so first, lubricants, because pterygia are associated with dryness. After that, then you could try an NSAID, but honestly, if it's really inflamed, I'd say start with the artificial tears. You can send to an ophthalmologist and we'll manage from there.
Perfect. And I think we'll take two more. What's the difference between preseptal and orbital cellulitis?
Okay, lovely. So the orbital septum is like a wall that guards the orbit from invasion of infection. But if it is breached, then the infection gets behind it. So that's what we call an orbital cellulitis. So if the infection is in front of the orbital septum, that is what you call a preseptal cellulitis. And usually vision is normal, eye movements are normal. So the eye itself won't be involved. It's really that the eyelid and the other tissues in front of the orbital septum are involved. So that's why the treatment is different. For an orbital cellulitis, they need typically admission and intravenous antibiotics, whereas a preseptal cellulitis can usually be treated with oral antibiotics.
Okay. And then the last question, and remember, Dr. Jordan, afterwards, you can actually go in and type the answers, as you know, is when you see a corneal ulcer, could there also be a foreign body perforation behind it?
A foreign body perforation. I mean, you can have a foreign body and a corneal ulceration at the same time, because the foreign body can introduce bacteria, fungi to the cornea and cause the infection. As for perforation, that can occur as a result of either the foreign body if there's trauma, or the corneal ulcer itself can erode through the cornea and cause a perforation.
Okay. Thank you so much. I hand over to the moderators. Thank you, Dr. Jordan.
All right. Thank you
Okay.
very much.
Thank you once more, Dr. Jordan, for that global view on the red eye. And we go into our second session. And our co-host for the second session is Dr. Peter Swaby. Peter, are you there?
Yes, I am.
All right,
Okay.
Peter. All right, you can take over now. All right.
Sure.
Thank you.
Thank you very much. Excellent presentations to all. Really very informative, and I think we've gotten a great treat. We're in for another treat because this is a question that we all have. Back to school in COVID-19 pandemic, the risk of increasing spread face-to-face versus online instructions. And this will be done by Dr. Winston Delahaye. And Dr. Delahaye is a Deputy Dean in the Faculty of Medical Sciences at the University of the West Indies, Mona, and a Consultant General and Addiction Psychiatrist at the University Hospital of the West Indies. He completed his MD at the University of Pécs in Hungary, his postgraduate degree in psychiatry at the University of the West Indies, and his master's in public health and Fulbright Fellowship in substance abuse at the Johns Hopkins University. He's an internationally certified addiction professional and a global master trainer of trainers in the treatment of substance use disorders. Dr. Delahaye is a member of the Medical Council of Jamaica, past chief medical officer in the Ministry of Health, and he has been past president in many different organizations, including the Medical Association of Jamaica, past president of the Jamaica Fulbright Alumni Association, the past union president at the University of the West Indies, and past president of the Jamaica Psychiatric Association. He's past chairman of Bellevue Hospital Board of Management, past chairman of the Board of Supervision of the Ministry of Local Government, and past deputy chairman of the National Council on Drug Abuse. Dr. Delahaye established the Medicinal Cannabis Unit in the Ministry of Health in July 2017, supervising the registration of 82 medicinal cannabis products in Jamaica. He's a former captain in the Jamaica Defense Force. What an incredible resume. Over to you now, Winston. Thank you so much for presenting for us.
Thank you very much, Peter. Been a while, haven't seen you a little bit. It's nice to know we're all keeping safe. So let me thank the organizers, the Association of General Practitioners in Jamaica. I've done a couple of presentations for them, usually surrounding substance abuse, but very happy in particular this topic to be addressing this for you. Just before I start though, I'll mention that in over 20 years of psychiatry at Mona University Hospital, I've had maybe 1 or 2 referrals from the ward to ophthalmology. I think there's an easy reason for that. When our patients say they see halos, colored halos around anything, it's unlikely we're interpreting that to mean an ophthalmology problem. So our topic, back to school in the COVID-19 pandemic, risk of increasing spread, face-to-face versus online instruction. And this is really a very timely presentation where it's certainly on us, these issues. And in fact, in recent times, we've had a number of publications in the media on this. So let's just start with our reality in Jamaica. And I'll just go through a couple of these areas on this slide, which I'll get back to you. So number of confirmed cases, over 9,000, certainly coming up to 10,000. That's a function of testing, obviously. Are we testing the most that we could? Resounding no. And in fact, I'll just hasten to say, and this is not time to be really trying to criticize persons, but the harsh reality is within the Caribbean, we're not doing the best. We've made mistakes, doing the best we can, I'm sure. Can we do better? Do we need to do better? I have to tell you yes, because when you compare number of deaths per population and you compare a country like Barbados or any other one of these islands, we're not up there in the top. I think we're all aware of that. And more importantly, a number of these deaths took place in and around the last 2-3 months. So we were doing relatively well until, of course, things stepped up, as it is with infectious diseases. The The number of new cases in recent times, maybe in the last 2 weeks, we've seen it go down a little. And I'll ask you the question, if the US, if Europe, including Sweden, are seeing their second wave, why would we be exempt? And so I just hasten to say, let's be very cautious in how we go about, in particular, seeing our patients. People in ophthalmology get very close to the mouth and nostrils. And so you're at particularly high risk, I think, along with ENT persons and so on. But the point I'm making is that we have a large number of active cases. We now have community spread. The picture isn't pretty. Can it get worse? Absolutely. And of course, in the midst of that would be school children. Our reality continuing, we project, or the Ministry of Health projects, about 1.5 million Jamaicans becoming positive. Of course, we are all aware of the silent spreaders, which is the asymptomatic and positive. That's the majority of persons. We have recognized community spread in this country, and therefore we must go about our business with the thought that we're all potentially positive. Most importantly, at this time, there's no approved vaccine that I'm aware of. We know the Russians have juggled, is the right word, with their vaccine, and they have something that they're using. The Cubans have a potentially good product. In the US, they have had a couple of trials and had to discontinue those because of some deaths, as you do in these studies. Doesn't necessarily mean the deaths are because of the vaccine, but that's what you do, stop and then explore. And so potentially we may have something in the first quarter of next year. It certainly is coming after November 3rd. We were told it would have been at or about November 3rd by a particular person who we no longer need to listen to when we watch our television. And so we thank God for small mercies. So the no vaccine is a real issue. We can't feel safe until we have that. Safety measures, therefore, that we've been implementing would include mask wearing, and I added there plus face shield. There's a relatively recent study which shows that if you add a face shield to the mask, recognizing that the virus can be transmitted through the eyes, in keeping with your theme, your ophthalmology theme, then that's really more foolproof than mask wearing alone. But it is not face shield to replace mask wearing. I must highlight that. Then hand sanitization, hand washing, soap and water is sufficient. I keep it simple in my radio talks. Wash your hands twice as long as you normally would, and do your best to get all surfaces in, including between the fingers. It helps to keep it simple for the general population. And then, of course, social distancing. We recognize the 6 feet. If it can be more, let it be more. And so therefore, things like bumping elbows, which I used to do, I don't encourage anymore, because that can't be 6 feet unless you have a very long arm. And of course, to add to the safety measures, minimizing social activities, group activities. It is why you're having your conference now in a virtual way. And I must congratulate you all. If you have 250 plus participants, that's by any measure a successful conference. But minimizing social activities, group activities, and more specifically, any indoor interaction. If you must interact, let it be outdoor. And the onus is on you. You determine where your body is. These are some basic principles in psychology. And so you don't need to knock someone inviting you to a little drink up. I've had a few invitations like that, believe it or not, in the last 2 weeks by very close friends who I would expect better from. You don't have to go. And so now isn't a time to accept an invitation to have drinks or eat some pork, as was the case last week from a friend. You don't need to say, let's see how it goes. That's a nice response. And you just don't go. Simple. There are clear aims to these current safety measures internationally. It helps with stemming community spread, helps with flattening the curve. I don't think to this audience I need to expand on what flattening the curve means, but essentially, by reducing the numbers ill at a particular slice in time, you reduce the load on your hospital bed capacity. We have in this country about 100 bed capacity. University Hospital sees a bulk of that, In fact, at one point, and I communicate very closely with Kyle, who is the medical person, the head of the hospital for University Hospital. We've gone up to 65, maybe even 70, and felt stretched, as you would imagine. It's very important that we protect the vulnerable, and by that we mean persons who are elderly and those with comorbid conditions, hypertension, for example, diabetes, or any other comorbid illness. We've also seen a relatively recent study recognizing that in the psychiatric population, our patients who generally are at a higher risk of dying compared with non-psychiatric patients. Don't know if you're all aware of that. Times maybe 2 to 3. That similarly for the coronavirus, it appears that the risk is heightened. The overall aim of all of these safety measures, I'm sure you'll agree with me, is to save lives, reduce the numbers in the hospital, reduce the number of beds you need to use up so you prevent persons coming in who will not have a bed space available. I personally know of someone who I've been close to, who even with my contacts at university and others, we just couldn't get the person in to the university hospital. They then went to another hospital and died. That's just a harsh reality we face. If we have many persons flooding our hospital, especially a referring hospital like the university hospital, then you're likely to have overcrowding and end up having positive persons in the waiting room or in areas of the emergency room where you just should not have that going on. You then have smell of smoke and a fire or potential fire, as happened in our emergency room. You now then need to move patients out and move those who must stay together, and you're now have heightened risk of those being in the hospital being exposed to persons who are positive. So all of that, the flattening of the curve, will help. But there's a big challenge, even with all that we're doing to prevent. You have long haulers, increasingly so, in about 6 countries that I'm aware of. Now, when I stay close to the literature, where persons stay ill for many months, 6 months and more. We have, in a number of countries, reinfections in about 5 or 6 countries, where persons were ill, were recovered with a negative coronavirus test, who then became reinfected. And there are a number of reasons for that, which we won't go into potentially, but it includes new strains of the virus. To my knowledge, it's about 6 or 7 different versions, change which viruses do, of the coronavirus. And then we bring into question, and if you've been reading the literature, you recognize that the whole concept of immunity is now very iffy. We're not so sure about that. One, we are unsure about how long that lasts. It may be weeks to months, is what explains the reinfections. And therefore, as an extension of that, this whole concept of herd immunity and let's have persons infected so that we can come back to a new normal, and we must be out there, usually comes from the persons focused on economy. They see it that way, and I understand why. But herd immunity, again, a big question. Even so, you need a large percentage of the population being infected with a large percentage of potential deaths to have herd immunity where it's possible. About 80%, if I recall correctly. But more so, if immunity is questionable, then so would be herd immunity. The silent spreaders, it would be a major challenge. The majority of positive persons are asymptomatic, and so they themselves don't know. And again, just to underscore the importance of seeing a physician before you get tested. A lot of testing is available in private labs now. I am aware of persons who just call to say, where do you have testing? And they're gone. I certainly think the labs should ensure that they have a referral. But again comes the economics. You know, if you have 20 people at your door at 8 in the morning wanting a test, you're in the business of making money as a lab. Why wouldn't you? But that's a challenge, because you then get back a result that's positive. You don't need to tell anyone. And so there's no contact tracing. And so clear in my mind that in the same breath, at the same time as we facilitated, I think it's now up to 4 or 5 labs as being ready to do testing, we should have ensured that they only test on referral from a physician, because that's how you're able to then send the result to the person who referred them, as well as to the patient. I think you should know your test results, but you can then report it to the Ministry of Health to do the contact tracing. We now differentiate contacts and close contacts. Any child who would potentially be positive will have close contacts in their homes. In addition to that, not all children are asymptomatic. The deaths that we see in Jamaica and internationally includes children. Yes, for Jamaica, I think the youngest has been 1 plus. We have a number of adolescents, teenagers in there. And so they don't all escape. And so to suggest that children don't get ill, let's just go ahead and have them interact, get positive if they wish. We certainly want to underscore the fact that we see deaths in children too. So they are a vulnerable group. More importantly, it's with some, and depending on the age range, with great difficulty that you get children to not interact, to play closely, to hug, etc., etc. So we must bear that in mind as we look at this question about reopening schools. So I'll just share with you, and she doesn't mind my sharing. I went to Arden. She's the principal of Arden, Mrs. Malloy, who on September 20th was the first tweet I was seeing surrounding school reopening. And that's not unlike her. She has no difficulty standing up for what she feels strongly about. And there's, as I'll just quote, there's absolutely no way that I will support the reopening of school face-to-face on October 5th with the rate of community spread of COVID-19 that Jamaica is experiencing. She then, because she's smart, said, I refuse to sanction putting the staff and student at that exposure, at this kind of exposure. And before that, she added, I may be forced to, but I refuse to sanction. So she's expressing how she feels. Even if she must, it's not with any comfort that she would. I then responded on September 21st, as a public health specialist and Arden alumnus, I fully support your position. And as I've pointed out then, your concerns are real. Every attempt must be made to streamline online learning, making it accessible to all students. This should be our focus, because I felt and still feel strongly about that. Let me just get back to my, okay. So certainly, as it relates to school children and exposure, students would be at potential risk of being exposed, the teachers, similarly, ancillary staff, everybody, security, those in the lunchroom, that's in the school environment. Let's now look at getting to and from school. Street vendors, again, our young son goes to Arden in second form, so I drop him to school when they are open. So you see the street vendors, they line Arden Road, at least 4 or 5. So they then would be at risk, the children at risk of contracting the virus from them and vice versa. Then bus occupants, not everyone drives to school. And so people are taking the bus, in fact, the vast majority. Having reached home, been to school, reached home with all of that transitioning in and out of public vehicles. Then in the home, the siblings would be at risk, the parents, and very importantly, based on the age range, comorbidities, grandparents. And so we must factor all of this in, even while we recognize the challenges with online learning. Have we seen this before? Absolutely. So in a Washington Post article of August 11th, we see where they reminded us that as it relates to the Spanish flu, which had nothing to do with Spain, by the way, we won't get into why it's called the Spanish flu at this time. Boston refused to close schools during the 1918 Spanish flu. That's at a time when you had 50 million deaths worldwide. So they opened their schools in and around mid-September 1918. Then children began to die. 110,000 children went out to school in mid-September 1918. When the deaths started, they then got smart, but if they did before, they could have prevented a number of deaths. They then closed schools again, as we've seen internationally this time around in 2020 in the last couple of months. They closed school again towards the end of September in 1918. So we know, we've seen this before. It's the same kind of virus, same method of spread. And so let's then come to the options available to our students. It includes online teaching, it includes audiovisual broadcasts, face-to-face learning, or a blended approach of all of that. In fact, as I was preparing, I was reminded it's very few groups, usually among psychiatrists, where you have two persons in a room and they come out with 3 opinions. That's meant to be a joke. But the point is, we can have a combination of these, and it doesn't have to be one or the other. Let's focus a little on the challenges. Currently in Jamaica, we have about 400,000 youngsters affected for a number of reasons. They don't have a laptop, they borrow their parents' phone, who feel frustrated that they can't have the use of their phone, with the associated cursings, etc., etc. Some may even get physically abused because I need to leave my phone with you. Real things. Connectivity at home, some may have no service. I happen to be a grade rep for second form at Arden, so we get the challenges, and there are persons in my son's class, maybe in your children's as well, who call to say, and they're being real, it's not a joke, they say the credit ran out, their child was bumped off, can I explain to the teacher that they'll be on tomorrow? Real issues. Bandwidth in schools, Arden was a little bit ahead of the game. There are a couple of other schools who were equipped and simply just transitioned to online learning. But the vast majority, I'd hasten to say maybe 98% of schools had to start in February, March, looking at online learning. We add to that semi-literate parents, that's a big issue in our country, or guardian having difficulty monitoring, assisting the students as they would have had in the classrooms, real issues. There are children with learning deficiencies in a face-to-face. A teacher may recognize that there are specific schools for those, but there are many persons with learning deficiencies, children in regular classes, where the teacher detects that even while the assessment is being sorted out, and the headmistress or form teacher is making contact with the parents to get some help, the required help and assessment. The teachers may recognize that and spend a little more time at that person's desk. That's hard to do in an online environment. Then, of course, we recognize and don't want to minimize the mental health issues. Children enjoy being in contact with their friends, need to be interacting. Isolation is a major issue. And more importantly, widening the inequality gap. So where poverty is present and whatever that leads to, inability to purchase a laptop, get data, etc., etc. All you're doing if you go online only is widening that inequality gap. The overall lack of supervision leads to a number of challenges because the parents must go out to work, and we've been seeing this. The CDA, they've documented issues of sexual abuse heightened, and of course the National Council on Drug Abuse, specifically alcohol, but I think it would apply to other substances. We just haven't studied it. An increase in the prevalence of substance use amongst youngsters, meaning they have access to alcohol, maybe in the house, in the household, the parents have gone, children get up to antics and they'll pour themselves a shot of something. Or the neighbors would be there who have this available. Or a corner bar, let's be real. The parents are at work, unable to restrict the children from being sent to buy a half Q, telling you real things. I see the patients. On the way back with that half Q, they then pour a little in the top of the half Q stopper and drink that. A number of patients I have were introduced to alcohol in that way. So there are a number of challenges which we don't want to minimize. And so really what you're looking at is weighing pros and cons in your decision making. A number of persons appropriately placed have been very vocal about these challenges. October 22nd, I think it was an Observer article, the JTA president, Jasper Gabriel, and I quote, "Online learning is here to stay, dangerous to public health as a result of community spread, it should be, of the novel coronavirus will pose an extreme challenge as thought is given to a limited return to should be face-to-face learning. And so this is in response to discussions around children in low-risk communities returning to the classroom. So in terms of the decisions to have a pilot project, it's called, by the Ministry of Education, in collaboration with the Ministry of Health, I have no doubt in my mind that they've really done the best they can in identifying which areas would be those where they can afford to start a face-to-face pilot. It generally includes communities with lower rate in terms of prevalence of the virus, close communities, communities where children, for the most part, probably walk to school as opposed to having to be exposed on public transport, etc., etc. A lot of thought has gone into it. But they've selected 17 schools for this 2-week pilot. It includes 12 primary and 5 secondary schools. Coincidentally, the pilot starts tomorrow. There have been a number of challenges. Some of the headmistresses, headmasters weren't informed, for example, and as a result, 3 schools opted out. This is part of starting tomorrow what they consider a phased resumption of face-to-face. What it will allow is persons who have no internet access, no laptop, whatever the reasons are, they're unable to log on to somewhere to learn, or the school simply doesn't have the capacity. There are many like that. They have the opportunity to go to school where, and again, I'm comfortable that they've taken the time to ensure they have appropriate social distancing, etc., and hand washing stations and so on, temperature checks. All good. And of course, in addition to that, we're looking at the Tablets for Students program. It isn't ready. And I think it's easily another 6 or so more months that we'll need to wait to get tablets into the hands of students. And so essentially, what all of this, and this is really the argument, the discussion, we're potentially increasing the risk of a new health crisis. We're not yet in our second wave. It's coming, rest assured. I didn't have to say that, but that's just a harsh reality. That's how public health works. Viruses have a lull, you then have a mix, people get complacent, and then you have a further spike. It's happened every time, including in the Spanish flu in 1918. And though I'm comfortable that all the measures will be taken, as they indicated at the Ministry of Education, in collaboration with the Ministry of Health, it's not without the risk of precipitating a new health crisis. So let's look at what the new normal code would look like. And I start by saying education is a right, not a privilege. And so we must ensure that the decisions we make facilitate the potential for every child to be able to learn in an appropriate way for them. And this could include face-to-face, keeping it as safe as possible. And so we're down to looking at options, which in a democratic society, which we love, that's why we're here. There are other countries who just tell you brethren is face-to-face or it's online only. And they ensure that people have the requisite tools to do that. We're not that kind of society, and I'm happy for our democracy. But virtual learning is here to stay. Inequality must be addressed, because otherwise what you have is those needed the education as possibly their only means of elevating themselves out of poverty would now be falling further backwards. And so in my mind, when I do the math, and you can think it through, a blended approach seems to be what's most appropriate, where you Zoom live teaching in classrooms, those with the ability to log on and do online learning may do so at the same time as, excuse me, persons are in the classroom exposed to this teaching. Having said all of that, it can't be about feelings. It should never be about the economy only. Our decisions must be driven by the science. And I'm sure, like me, you're all happy that Fauci is back, will be back. We haven't had that challenge here. I think we've been going by the science. I don't think it's been easy. But overall, I think our Ministry of Health, they've done a good job. Yes, on about April 8th, I knocked them a bit about the mask issue. They wisened up and they're now certainly recommend mask. Other things can be done. But overall, our people, our ministry, they're doing a good job. Let's continue to make the decisions, have the decisions driven by the science, and ensure that the decisions we make will, one, facilitate learning for all, and two, keep us, our children, and the rest of the country as safe as possible. And so I close with my response to the topic, yes to live teaching. That allows for two options. If you have no other choice, you may go in as safe as possible, sit and learn. Those who may, having paid their school fees, because you have to pay your school fee, you don't log on without paying your fees, rightly so, you may learn from home. As we get into January, this is likely to be the direction that we're trending. And then let's see, as we get to vaccinations, I'm pretty sure that there are very few anti-vaxxers is the term they use in this population, in this group. But there may be. I am and will be the first with my children and family behind me in line for any FDA-approved vaccine becoming available. So let me thank you very much. I hope I've shed some light into this dilemma that we face. Thank you.
Thank you very much, Winston. That is a very sobering and timely presentation. And I'm sure there are lots of questions for you. Sam, do you have those questions that you want to run through with Dr. Delahaye?
Sure. Thank you very much, Dr. Delahaye, for your presentation.
You're welcome. Happy.
Let's see if we can just ask you a couple of those, Winston. One question is, are we still doing contact tracing since we are in the phase of community spread?
Yeah, the answer is yes. Is it as it used to be? Just my personal feeling, I don't think so. Should it be? It shouldn't change. It must be the same. If you need more people, you employ them, you get the requisite funds to ensure they are out there. It's the only way that you're going to reduce the spread and really flatten the curve, by contacting those at risk, testing them, and doing the necessary action from that.
The second question here is there an online platform for general practitioners to report cases, or even better, could there be someone liaising between the private labs and the ministry to ensure that there's no duplication of reporting, maybe use of TRN as well?
Yeah, so, and that would be very wise. And there's a reason we have presidents of association. So I'd say the president of the AGPJ should write a letter to the ministry with exactly that you just said, that we ensure there's a liaison and online access to reporting.
Okay, says, what about med students who are being forced to pay additional 20,000 to enter hospital practice per month, 20,000 per month to enter hospital practice?
Hearing that for the first time. What does that mean?
Who asked that question? Can we get a clarification on that question? Oh, it's William. When did you hear that?
William Brown, yeah.
Yeah.
William, can you expand on that for us?
Hold on a second. Let me let him actually use his microphone. Dr. Brown, can you activate your microphone, please?
All right. You can hear me now?
Yes.
Yeah.
Yes, we can.
Hearing you, William.
Yeah, man. During the last 2 days or the 3 days, the medical students have been complaining, the guild, that they are being asked to pay $20,000 each month to be provided with PEPs, personal protective gear, to for them to start their hospital practice as in third-year students. And there was a big discussion with the authorities over there. I don't know if they have come to any conclusions or solutions, but it's hot. It's hot at the university. They cannot pay $20,000 per month for personal protection gear. And it's on the radio. They've been discussing it beyond the headlines and all that on RGR for the last 2-3 days. So you can ask more about that. You can check on it. Thank you.
Important question, William. And as you know, I mean, my office is beside the deans. So I'll certainly follow up on that. I wasn't aware of that discussion. That's important because that could be prohibitive for many. If they have a challenge paying school fees, let alone 20 grand a month, I can see where that would be a challenge for many.
Question from Arna Morgan. Doc, I've listened, but what do you mean when you say you're for face-to-face teaching?
So just for clarity, so all I'm suggesting is for those who can't do other than face-to-face, we should make that available for those persons who would wish to go. That's not necessarily those without laptops. There are persons with laptops who learn better in a direct environment, face-to-face, and the parents know that about their children and would want to send them. Again, I'm comfortable that the practices in the schools as established by the Ministry of Education in collaboration with the Ministry of Health are good enough in terms of distancing and so on. I've gone into the classroom, and at least one, and seen what they propose, and the hand sanitizing stations all around. Many schools have cameras all around. So they have things in place to ensure that that's happening. So that's what I mean. But a live broadcast by whatever means they use, Google Classroom is what Arden uses, or if it's Zoom, it doesn't matter. But you're having one teacher doing his or her class, which is potentially available in a face-to-face physical setting, and at the same time by Zoom or Google Classroom. That's what I mean.
So you're saying that you like a blended approach where possible.
That's correct. That's correct.
Okay,
Dr. Delahaye, are you aware of the ministry putting in any additional support for these children who will fall behind as a result of not being able to access online learning? Because my understanding is that there is quite a number of kids who are not able to access online learning and they are falling behind. Is there any consideration for the Ministry of Education to put in any facilities to kind of allow these students to catch up?
So the number is actually about 400,000. It is a large number, as you say. I don't know the details, but I know that there's a lot of discussion around and funds being provided, for example, to these pilot schools. The 17, I think it was, schools that they start tomorrow with this face-to-face pilot. They're provided additional funds to facilitate those things. But specifically for those who would have fallen behind. So for example, I am aware of students who have not been on, period, since schools have reopened in a number of classes. As I said, I'm a grade rep for four of the forms at Arden. What do you do with those students? And so there needs to be some remedial method of providing remedial learning for these students. So I don't know, but based on the trend, I'm sure they are aware of these challenges in the ministry and are looking at ways of addressing this.
Another question, are there any assessment or evaluation of this psychiatric or psychological effect of this no school on any of these students, like taking out a cohort of them and assess them to see what has been happening to them?
Yeah, and that's a very, very important question. We have a number of residents now, like ophthalmology. I have to tell you, I forgot to mention that. So in my time at UWI in casualty and so on, I didn't see the number of residents I see now looking at your list of presenters. And the same happens in psychiatry. So we have a number of residents now, and it certainly is one of the areas, at least 2 or 3 of them I'm aware of, looking at mental health issues, and it includes in school in terms of child psychiatry components of the program.
All right, thank you.
All right, so Dr. Subi, there are a number of questions. I don't know if you want us to kind of go through them. It seems quite topical. think persons are really interested there. So I'll take your guide before you move on to your next presenters.
So can you take over for me, Sam? My internet seems to be giving problems here and I keep tripping in and out. So I think we have a few more questions that we can take for Winston.
And then we move on to
Dr. Happily.
All right, so sure, no problem. So let me go to Dr. Ying. Dr. Ying said, congratulations on an excellent presentation. Considering the inequality of electronic access to education, especially in rural areas and children being seen as super spreaders of the coronavirus, would you consider venues such as a community center with video monitors or monitors erected in the center of a small township as reasonable alternatives to going into classrooms?
So one, there's a method to determining where you have schools, and it takes all of those things into consideration. And so they serve a particular region, a particular number of persons. If you get down into community, I think some mics are on.
Yeah, I'll stop those mics. Go ahead.
Right. If you get down to a community level, already it's an expensive venture that should be afforded, I think, they must. But to get down to a community level, you're talking now 20, 30, 50 times the level of expense. And so, yes, many times we start somewhere. I think starting with a school in the schools would be useful. And overall, I think if we should go to a community level, the kind of expense you're talking would probably make the whole project prohibitive.
Fair enough. I'm not sure you can answer this one. From Dr. Nicola, if the disease does not provide lasting immunity, what are the odds that a vaccine will?
That's an easy answer. That's why you have clear guidelines, which people go through, including clinical trials. If the FDA says they approve a vaccine, it means it has met all the criteria, including a nice number of persons who would remain well for a period of time. So the FDA approval answers all of that, but I understand the question.
Okay, fair enough. The next question from Dr. Brown again. Could government start vaccination at a small cost, funded by NHF for students?
Frankly, I think the vaccines must be free. This is too big an issue for there to be any cost. And so that's kind of funding. I would expect that the government would have things in place as soon as you have vaccines. Of course, you'll appreciate I'm not necessarily close to the administration at this time.
Okay. I see just a statement. This isn't a question from Dr. Ware. Just to say that contact tracing is still being done in the parish by parish health departments. Dr. Ware from the St. Catherine Health Department letting us know that that is happening. Dr. Arna Morgan, is there a place for Zoom meetings where the teacher is distant and the students are at the schoolroom with a younger teaching attendant?
Yeah, and that's a novel idea. Sure. What it means though is a smart board in the classrooms. Some schools have it, Arden has it, but that's not every school. So that's a kind of challenge that you're talking about. Again, let's not forget all of these items have a cost ticket, a ticket to it in terms of monetary value. And so yes, it would be novel, but the challenge of increased costs.
I mean, just to add, I think the consideration of numbers as well, where in your model, one teacher is in a classroom and the students are remote. You may have 30 students in a classroom with one teacher remote. That protects the teacher, not necessarily the children.
Correct. You are correct.
Could a small sect be immunized, that is those who have the science lab projects in prep for exams?
All right, so I'll take that wider. And so one method which I've thought through, and there are a number of persons who are of this view, that it really should be the exam year, the 5th, the upper 6th, CAPE 2, it's called now, that you focus on and get those to come in. I can support that because they need the assistance, the lab work, etc., etc. So I can support that. But how does that address the overall inequality? And so you're going to be leaving hundreds, thousands of first, second, all the way, the other forms, persons with that lack of interaction for a whole school year. Can you imagine what repeating everybody now in first form would mean if we had to? So those who would do an assessment, there are a few bright ones, not all persons are, and should be allowed. Again, the one response to that is education is a right, not a privilege. So we have to focus on the overall picture.
Thanks, Doc. So we'll just 4 left. I won't take any more after these. Why, from Dr. Scott, why have the same approaches that has happened in the schools not happened in our hospitals? Examples, social distancing and hand washing.
But that obtains in our hospitals with a little more difficulty. I mean, to be real, if you enter the emergency room, maybe less so now, but a month ago, people are on the outside. We're at the point of having to consider a tent to put persons in, just waiting to be seen. At the point where persons brought in a vehicle had to wait in the vehicle until we sorted out a space, especially if they had symptoms suggestive of COVID-19, before they could come in for up to a time aware, an hour, 2 hours, even 3. Harsh reality. So there was crowding. So that's the concept of flattening the curve. So you don't have this kind of crowding, large number of persons descending on healthcare facilities.
Dr. Scott replies to say he's at KPH, A&E, and none of these measures are in place.
Yeah, so I mean, he works there, so I'm not disputing that. They should be where you have larger numbers, and especially where you may have challenges of behavior. That's not new to our society. Then it's with great difficulty that you do that, There's a place I pass regularly, JPS. These are persons just waiting to pay a bill. And they have marks on the ground out there, nicely organized with distancing and so on. And a man comes up and just says, well, I'm now wait. And he goes up to the door. What are you going to do? Comes up right behind you. Your only choice there is to
Physical
leave.
altercation.
That's correct.
Yeah. It happens at the supermarket as well, right?
Correct.
So Dr. Adrian Pringle, what about physical activity, including sports? Are we to brace for more chronic illnesses in the long run?
All right. So there is that outcome, negative outcome of all of this activity, the coronavirus issues. And it's likely to produce increased non-communicable diseases. That's a negative spin-off. I'm happy to report that. So my son, I know, does online school, and they actually have exercise classes online as well. So there's at least an attempt as it relates to the school to have engaged students in online activities.
All right, perfect. Then we go to the next question. What about the use of community blackboard for kids who can't access internet? Great idea from a teacher, government help needed. What's your opinion?
Right, so I'm sure they have those things on the books. You have to start somewhere. They're starting with a pilot project with a face-to-face in the schools. It's the same kind of question as we had earlier about a community setting. So yes, it can be supported. That's not very expensive, but then you have the one teacher teaching a class, and to determine how best you capitalize on that, you can reach more if you can have that person in a physical setting with 30 persons in the class and also beamed to another 30 or 60, as opposed to in a community setting. But I don't know that they would rule that out.
Yeah. So Dr. Arna Brown Morgan is asking, the flu vaccine is repeated yearly. Could we be looking at something like this for COVID-19?
It's a highly likely position that we'll arrive at, without a doubt. There's a reason for that. So the viruses change. And by the way, I'm not so sure you're all aware, so Jamaica contributes to the making of that vaccine in terms of being a viral center at our microbiology unit, the viral center there. And so that's how it works. You have persons becoming ill this year, you send off to Geneva or wherever it is, the samples, and from those they make using attenuated viruses or any other means, they make the vaccines for next year. It is likely that that's how the coronavirus vaccine will be.
Dr. Delahaye, Thank you so much for your presentation, your time, your wisdom, and of course, this wonderful presentation. As a former Ardenite, the Duke Quarry up teamer, big up yourself.
I suspected.
I've been holding that one. That one was coming. So no, thank you very much. I see Dr. Swaby, you're back. I'll hand over
Yes,
to you
I'm
to
hoping that
introduce
my.
Dr. Hastings.
Yeah, sure. Just one more thing. Winston, why don't we mandate mask wearing? I mean, it seems really counterintuitive to just suggest it rather than enforce it.
I agree with you. I mean, in another capacity, only a few months ago, I was pushing for that. I no longer represent that kind of position anymore, but without a doubt, purely on medical grounds, it needs to be done. One of the challenges you have is where people got defensive on a particular issue, they have difficulty now freeing up to say, I was wrong. We're not a society like that. I was wrong. We should mandate. Unfortunately, most of us don't think like that. That's all that's required. Just don't feel no way, nothing wrong. Doesn't mean I was right, you were wrong. We're helping people. Still could be done. So that's, like, for example, one of the measures that we still could do to help more in Jamaica.
Can I say something?
Go for
in
it.
our society, it's easy to mandate it, but can we actually enforce it? Because, we're a very indisciplined society.
Yeah.
I mean, it's easy to mandate stuff, but can we actually enforce it? I'm sure it would cause a lot of confrontation between citizens and the police force. Look at all these confrontation with at these illegal parties that is resulting in the death of 2 policemen. Can we seriously talk about mandating it?
Hey, a better example, only last night, yesterday, at a party, a policeman sees a wanted person with a gun, proceeds to try to arrest him, and was stoned and shot and killed by other persons present. So that's just in keeping. Nonetheless, in terms of a decision and directive of a government and a ministry, it's the least we could do. There are those who will listen who otherwise would not have worn a mask, but just hearing now that the ministry says it's mandated may wear. So I think it's the least we could do. So at least we're doing the right things for those who may toe the line. Otherwise, what we do is accept that our people are tough and don't want to try.
So if I could add, and just to say that I agree, but I think a part of it is the mentality, as Dr. Gordon said, and the indiscipline. I do find that we have to find a way to incentivize Jamaicans. Perhaps turn it into some form of competition. Best mask win this. You get a discount for services here and there. Right.
I see you went to Arden.
Definitely. Best only school in Jamaica.
On Arden Road.
Have our own road. That's right. So I don't know. Maybe that's something to consider, just how you can incentivize Jamaicans, because once you do that, then they really kind of start to get behind certain brands. So maybe the fanciest mask or the most colorful mask, the best looking mask, things like that. And there's some incentive at all of the government institutions and private institutions alike as a partnership project.
Well, definitely some food for thought there. Winston, thank you so much for a thought-provoking presentation. Really appreciate the time to engage us in this way. And you look like you need to be a president of something else soon.
Well, we have something to run off until then.
All right.
Thank you very much. All right.
All right. Thank you very much.
All right.
Our next presenter is Kimberly Hastings, Dr. Kimberly Hastings. And she's a 4th-year resident in the DM program of ophthalmology at the University Hospital of the West Indies. And she's going to be speaking to us on squints and strabismus. Without any further ado, Kimberly.
Thank you for having me. I am just getting my screen ready. I need to move this around. I'd also just like to note that Immaculate Conception High School is a very good school as well. I'm trying to just move this out of the way. Pardon me. Oh, I think I stopped my video. Can you still see me?
I can see your video. I think if you just move it up, it kind of, right, it kind of disappears. So just hover over it and try and drag it upwards. As
Oh,
you did it done before. Yeah, take your time.
sorry about that. I'm not sure why it's acting up.
Hold on a second. Let me see if I can get control of your screen.
I will approve. Let me
problem.
escape and then try to use my cursor.
Right. Let's do another search. Let's share again from scratch.
Sure. Sorry for the technical difficulty.
It's fine. Is Immaculate on Immaculate Road though?
You know, no, but it doesn't matter.
Right.
All right, I think we're there now.
Yeah, everything looks good now.
All right, thank you. All right, sorry about the delay in the beginning of the presentation, but today I will be talking about squints or strabismus and its management. I know it's a topic that people sometimes try to shy away from. Even sometimes us as ophthalmologists in training at a junior level, it can be very intimidating. So I'm going to do my best to relay some information to you guys today. All right. So these are objectives. We're going to go through the definition, a bit of the nomenclature and classification, some very general anatomy, the types of deviations, key aspects of clinical examination, and management. So the definition. Strabismus is actually derived from the Greek word strabismos, which means to squint or look obliquely. It is ocular misalignment caused by anomalies in neuromuscular control of ocular motility or abnormalities in binocular vision. In terms of classification, we can look at it based on the age of onset, the type of fixation, the direction of deviation, and whether or not it's latent or manifest. And by that, latent meaning hidden, so it's not exactly obvious when you're just generally looking at the patient, versus manifest, which is usually obvious when you're looking at the patient. Sometimes it might be very mild, but it's still there. So in terms of age of onset, we can categorize this into infantile versus acquired, with infantile being defined as a deviation being documented before age 6 months, and acquired with the onset of deviation after 6 months, and after 6 months after a period of presumably normal visual development. In terms of fixation, so it can either be alternating or monocular. Where alternating, there's spontaneous alternation of fixation from one eye to the other, versus monocular, where there's an obvious preference for fixation with a particular eye. So some important nomenclature to note in terms of our prefixes. So we have ESO, which can either be esotropia or esophoria, but ESO means that the eye is rotated inward, so the cornea is deviated nasally. EXO is where the eye is rotated or deviated outward or externally, temporally. Hyper is where it's rotated superiorly, and hypo is where it's deviated inferiorly. Suffixes, which I just mentioned just now, so they can either be aphoria or atropia. And the difference is with the phorias, it's usually latent or hidden, as I mentioned earlier. The deviation is controlled by fusion mechanisms so that the eyes under binocular conditions are generally straight. Usually when we examine the patient, or you in your office could try doing the cover testing, that is when we tend to bring it about. Atropia is a manifest deviation, so it is more obvious when it is at the patient walks. You can see the obvious exo or ESO deviation, and this exceeds the control of the fusional mechanism, so that misalignment is present under binocular conditions. This type of deviation may be constant or intermittent. And this is just a picture just showing you, if you look at the pair of eyes to the left of your screen, which would really correlate to the right eye of the patient if they're staring at you, we have the different examples of the deviations. So the top picture shows it turning inward. That's an ESO deviation. Outward for the second, that's an exo deviation. Upward for the hyper, and hypo is downward. All right, so some general anatomy. So we're just going to generally remember the different extraocular muscles involved with movement of the globe, as well as their action and innervation. So as you can see here, it's a very simplified diagram showing our extraocular muscles, and this is the left eye. So we have our recti muscles. This is another view. We have our medial, lateral, superior, and inferior rectus, or recti muscles. And we have our obliques, both superior and inferior. This is another picture that shows you the relation to each other and the posterior aspect of the globe to get an idea or just a reminder of its insertion and origin. So we're not going to go into great detail here, but this slide depicts the difference in terms of directions of movements of the globe, the extraocular muscular movements. So we have our lateral and medial recti muscles. If you note that those are the only ones that only have one primary direction of movement, whether it's adduction towards the nose, abduction away, while our other muscles have up to 3 or tertiary actions. And this picture just shows you nicely the different directions. And in terms of our innervation, so we have our oculomotor nerve, that's cranial nerve 3, responsible for the innervation of your superior, medial, inferior recti muscles, as well as your inferior oblique. Your trochlear nerve, cranial nerve 4, which innervates the superior oblique muscle, and the abducens nerve, cranial nerve 6, which innervates the lateral rectus muscle. If you all remember from med school, that little mnemonic formula, LR6SO4, and I added R3, where your lateral rectus is innervated by cranial nerve 6, superior oblique 4th, and the rest are 3rd. So the types of deviations, as we said, you can have ESO, EXO deviations, and those are subcategorized under horizontal strabismus, and any vertical deviations, which would be a hypo-hyper vertical strabismus. All right, so ESO deviation, this is a convergent misalignment, so it's turning inward. And as previously mentioned, our important suffixes, it can either be a phoria or a tropia, where your phoria is not obvious when you're looking at the patient, you have to bring it out in the examination, or the tropia, which is manifest or usually obvious when looking at the patient generally. It is the most common type of strabismus, and its prevalence, it accounts for greater than 50% of ocular deviations in the pediatric population in the US. In terms of your exo deviation, so this is divergent, meaning going outwards. Again, can either be a phoria or a tropia. It is the second most common form of strabismus. However, depending on the demographic, so in the Asian ethnic group, it actually is more common than ESO for the Asian ethnic group. And it's very important to make mention of our pseudo deviations. So this occurs when there's an appearance of strabismus, whether it's ESO or EXO deviations, when in fact the eyes are adequately aligned. So usually this may result from having a flat and broad nasal bridge, prominent epicanthal folds, or a narrow interpupillary distance in the case of a pseudo esotropia, or a wide interpupillary distance in the case of a pseudo-exo deviation. I have an example here of a little infant. So just generally looking at this infant, if they were in front of you, you'd almost want to say definitely there is an inward deviation of the eye, particularly that patient's right eye, which is to the left of your screen. However, I bring your attention to a very little white dot in the center of the pupil. That's actually a corneal light reflex, which I will get into later in the presentation. And this is very integral in helping us to differentiate between whether it's a true deviation or a pseudo deviation. And in this case, the fact that when we shine that corneal light reflex, we shine the torch and see the reflex centrally, it confirms that this is actually proper, straight alignment. There's no presence of deviation. The vertical deviations, not as common as their convergent divergent counterparts, but generally speaking, we describe them according to the resting position of the deviating, non-fixating eye. So the pictures I have here, the pair of eyes, the eyes to the left of your screen, which should correlate to the right eye of the patient. You can see in the first one, the eye is upward, that's the hyper, which I showed you earlier, downward, the hypo. All right, so in terms of our clinical examination, there many aspects of it that are important. All aspects of the clinical examination is important, but for the purpose of this examination and just to go through some of the things that you can do in your office at that first meeting with the patient, I would go through the red reflex, the testing of the pupils, that corneal light reflex you've been hearing me talk about, the Hirschberg corneal reflex test, the cover test, and just quickly give you a picture of a posterior segment or the fundus photograph of a particular condition I want you to see. All right, so the red reflex examination. My colleague, Dr. Yap, made a very important point in terms of the presence of leukocoria and what that could mean. So this is done in a semi-dark room at a distance of approximately 1 meter from the patient. Using the direct ophthalmoscope as a light source, we assess for the clarity and symmetry of the red reflex that we're seeing. This simple technique will highlight the presence of ocular misalignment and also whether or not leukocoria or the white reflex is present. So leukocoria. This is the presence of a white reflex in place of a normal red reflex. This finding is of paramount importance and requires urgent referral to an ophthalmologist for further evaluation. Reason being, differential diagnoses include both sight and life-threatening conditions. Sight-threatening, namely cataract, retinopathy of prematurity, which my colleague went through earlier, persistent fetal vasculature, and life-threatening, namely retinoblastoma. Retinoblastoma is very crucial in terms of identifying or detection. It's the most common intraocular malignancy in the pediatric population, and 25% of cases of retinoblastoma will actually present with strabismus. In terms of testing the pupil, again, Dr. Yap went through some of this earlier. So we assess for asymmetry, the presence of an RAPD. If there's a unilateral fixed dilated pupil, this has clinical significance, especially in the scenario with the adult patient who presents with a squint, where the affected eye appears to be down and out. And if this same ipsilateral eye is accompanied by a fixed, non-reactive dilated pupil, this is a neurological emergency. Reason being, we have to entertain the possibility of a third cranial nerve palsy pupil involving. So this presents with some combination of ptosis, mydriasis or a dilated pupil, and ophthalmoplegia, the so-called down and out strabismus. I have here my diagram, which again also Dr. Yap went through. So you can see it looks from a distance, or when the patient is walking into you, it looks like they have a squint, right? And reason being, when I went through the innervation earlier, remember we had a significant amount of your extraocular muscles being innervated by cranial nerve 3, whereas our LR, lateral rectus, and SO, superior oblique, were innervated by their own respective cranial nerves. So therefore, if we have a cranial nerve 3 palsy and these other nerves are left unopposed, then it will pull in the direction of those extraocular muscles. So unless proven otherwise, clinical findings in keeping with an acute third cranial nerve palsy with ipsilateral pupillary dilation is caused from a compression from a posterior communicating artery aneurysm, and thus urgent referral will be required. All right, so let's get into this corneal light reflex test that I've been speaking about. Unfortunately, my cursor is not coming up, so just bear with me as I try to explain everything. So it is a simple technique using a light source to assess for the presence of ocular misalignment. The patient sits in front of the physician, and a light is shown at near distance in front of the eyes. A normal examination finding entails a light reflex landing on the central aspect of the cornea. So in our diagram here, with a pair of eyes, the eyes to the left of your screen, which will correlate to the patient's right eye, all of that column there has a normal corneal light reflex. It's perfectly in a central aspect of the cornea or within the pupil. With respect to the eyes on your right, so you can appreciate that the reflex is in different directions. So if it is that the patient has an inward deviation, as you can imagine, if you're holding that torchlight perfectly central, however, the reflex lands more temporally, then it suggests that that eye has turned inward. Otherwise, if it is the opposite way, if it is that you're holding it centrally and you notice that the reflex is more nasally directed, then it suggests the eyes turn outward. And with regards to your vertical strabismus, if it is you're holding the light centrally and the eye is deviated upward, then the reflex will be present lower on the cornea. And the opposite is true for hypotropia, If the patient has a downward deviation and you're holding the light centrally, then the reflex will be present more superiorly on the cornea. So these are some actual pictures here. So we can see, so the large picture to your left, we can see that the light is being shined perfectly central, as evidenced by the central corneal light reflex to the eye on the right of your screen. However, when you look, the inward deviation of this patient's right eye, which is to the left of your screen, has the corneal light reflex more externally or temporally. This is the same infant we met with the pseudostrabismus. So again, even though generally it looks as if there might be the presence of an inward deviation, that central corneal light reflex is in fact present. So therefore, there's no true deviation. It is a pseudo deviation. This one is very mild, but that last picture to the right of your screen, this patient, if you look in the eye to the left of your screen, which is the right eye of the patient, that corneal light reflex is very central. The other eye to the right of your screen, which is the left eye of the patient, you can see it's slightly more inward. So this would represent a mild exo deviation. All right, so our cover testing. We have the single cover test, which is the cover uncover test, and the alternate cover test. I have a video to show you, so it will accompany my slides, about 2 or 3 slides following. So just bear with me as we go along. So the single cover test is important in the detection of latent strabismus, as well as differentiating aphoria from atropia. The alternate cover test aids in determining the amount of deviation present and can objectively be measured with adjunctive use of prisms, which we will do. All right, I'm not sure, can you actually all see me?
Yeah, we can see you, Doc.
Okay, great. So I just want to do a little demonstration. I have my occluder here. I'm going to act it out, but the video will play as well. But I just want to do this in order to help you to know what to look out for in the video. So for a single cover test, otherwise known as our cover uncover test, I'm going to utilize my right eye as the eye that has the pathology. So in assessing for the presence of aphoria, remember we said that aphoria, it may not be very, very obvious when the patient walks into the room to you or to us. And so it's upon examination that we will reveal its presence. So I'm going to use the right eye. Let's pretend that this patient possibly has a right esophoria. I'm going to put the occluder in front of the right eye of the patient. This is me covering. While the eye is being covered, underneath, the eye will actually turn inward if there's an esophoria present, so that by the time you uncover, you'll notice that there's movement to go back in a straight position. And you repeat it. Underneath, when you cover, it deviates. When you uncover, it goes back straight. So when we're assessing for aphoria, we're only assessing the eye that we're actually occluding on and off. All right. So if aphoria is present, the eye will deviate under the occluder, and when it is removed, the eye will return to a straight position. All right, when we're assessing for atropia. So yes, we said that usually for atropia, it's generally obvious when the patient will walk in, but in those instances, for example, when it's a very mild atropia, we can utilize the single cover test to help to bring it out. So when we're assessing for the presence of atropia, we actually are going to observe for movement in the contralateral non-occluded eye. So again, let's do a reenactment. Let's say the patient comes in and we're querying the possibility of a very mild exotropia. So I'm going to cover the right eye of the patient. If it is that there is a mild exotropia, when the contralateral occluded right eye is occluded, you will see movement of the unoccluded eye to a straight position. When you uncover, you see it slowly come out, and you repeat the test, and you're observing the opposite eye for atropia. Any movement seen indicates that atropia is present. So for the tropias, we're looking at the opposite uncovered eye, and for the phorias, we're looking at the covered eye. For your alternate cover test, it's usually performed after the single cover test, and the examiner occludes one eye and then the other, and is switching back and forth. This prevents the patient from having the opportunity to have binocular fusion in between, because when we're doing the previous test, the single cover, otherwise known as the cover uncover test, we paused every now and again to cover on cover, and we gave them the chance to fuse again. But when it is you do the alternate cover, we prevent them from having binocular fusion in between. This reveals the presence of an alternating strabismus, and when we combine it with the use of a prism, we can actually measure the deviation that's present, and this is integral in terms of planning surgical intervention if needs be. Okay, so I have my video here. I really hope it works.
The first type of cover test is the monocular cover-uncover test. It is the main test to differentiate aphoria, a controlled or latent strabismus, from atropia, a manifest strabismus present under binocular conditions. Cover one eye and look carefully for any movement in the non-covered eye. If the uncovered eye must move rapidly to fixate on the target, atropia is present. When atropia is present, the patient has a deviated eye both before and after the test. Either the same or the opposite eye may deviate depending upon which eye is fixating. Aphoria is demonstrated by movement of the covered eye just after the cover is removed. Since aphoria becomes manifest only when binocularity is interrupted, the patient will have straight eyes both before and after the cover-uncover test.
Okay, I hope that was nice and clear. All right, so as it relates to the posterior segment examination, a dilated fundus examination is critical to identify any retinal lesions that may be present. Pathology such as scarring at the macula or retinoblastoma can be identified with ophthalmoscopy, and an appropriate management plan can be made. So I included this, yes.
Sorry to interrupt. So one person is asking if you could play the video again.
Sure.
Dr. Jarrett. Yeah.
Sure, no
It
problem.
came through very clear on my end though.
Okay, no problem.
The first type of cover test is the monocular cover-uncover test. It is the main test to differentiate aphoria, a controlled or latent strabismus, from atropia, a manifest strabismus present under binocular conditions. Cover one eye and look carefully for any movement in the non-covered eye. If the uncovered eye must move rapidly to fixate on the target, atropia is present. When atropia is present, the patient has a deviated eye both before and after the test. Either the same or the opposite eye may deviate depending upon which eye is fixating. Aphoria is demonstrated by movement of the covered eye just after the cover is removed. Since aphoria becomes manifest only when binocularity is interrupted, the patient will have straight eyes both before and after the cover-uncover test.
Perfect.
Okay, I hope that was clear. All right. So in terms of the posterior segment examination, as I had mentioned, it would help us to reveal any existing retinal lesions, whether it's macular scarring, or as we're trying to drive the importance of the presence of retinoblastoma. So I decided to include this photograph to give you an idea of what that fundus examination could look like. So when it is that, in your office, you do initial red reflex examination and you see leukocoria, and it's a possibility that one of the differential diagnoses might be retinoblastoma. When we have a look when we're doing fundoscopy, this is the type of lesion that we could see. And as you can imagine, a lesion of this nature being present would affect the general proper reflex, the red reflex that you would see, and have that white reflection. And it's very integral. During this talk, I mentioned the concept of amblyopia. So this is a failure of normal neural development in the immature visual system. It is caused by abnormal visual experience early in life due to strabismus, refractive error, or visual deprivation. A crucial aspect in the management of strabismus is to prevent this from occurring. Vision loss due to amblyopia, depending on the cause, is preventable with timely detection and intervention. So let's get into management. So management can be classified into non-surgical conservative or surgical. So non-surgical management would include, so if it is a case where there was a refractive error, then we would correct this refractive error, and we may or may not include prisms. Occlusion therapy in the form of patching or penalization. So this is done to the fixating eye in order to engage the deviated eye to make it work harder, so to speak. On the note of penalization, this can be pharmacologic, where we would instill the use of cycloplegic agents, dilating drops, to essentially blur the vision, especially useful in a pediatric population where they're likely to tear off or remove the glasses or the actual patch that may be there, as well as optical means via spectacles with a deliberately inaccurately placed prescription. And in terms of surgical management, this is indicated if deviation does not resolve after about 6 months. It is said that the best sensory outcome is said to be achieved when motor alignment is done before 7 years of age, or if the duration of the strabismus is less than 5 years. There are two main methods of alignment in the extraocular muscles. I won't go into too much detail, but I want to introduce it to you. And they're namely recession and resection. Depending on the measured angle of deviation, which we would have done utilizing our corneal light reflex and the prisms, a corresponding amount of the muscle in millimeters would be manipulated intraoperatively. So recession, this is considered a rectus muscle weakening procedure. What we do is that the muscle is disinserted from its point of origin, and it is brought back and sutured posterior to its original insertion. And as I said before, in terms of how far back we go, we are guided based on tables that are created from ages ago that we follow in terms of a protocol. And based on the amount of deviation as present, it maps up to the amount of millimeters of the muscle that we should manipulate. So essentially, recession, as I said, is disinserting the muscle from its original position and inserting it based on those guidelines posteriorly to its original point of insertion. Versus resection, this is considered a rectus muscle strengthening procedure in that it surgically produces a tightening effect that aims to offset the opposing action of the antagonist muscle. So a part of the muscle is actually resected, and the new end of the muscle is sutured to its normal insertion point. So again, guided by guidelines and protocols, we would actually resect a portion of the actual extraocular muscle based on the amount of deviation present and bring that new end forward and suture it to its original position. So in summary, strabismus is defined as ocular misalignment due to dysfunction of binocular vision or neuromuscular control of motility. The age of onset, etiology, as well as time of detection has clinical implications on management, prognosis, and outcome. Straightforward exam techniques can aid the primary care physician in identification of strabismus, and appropriate referral to the ophthalmologist can be made. And the red reflex test is simple, yet crucial in the recognition of life-threatening conditions, namely retinoblastoma. These are my references, and I thank you for your time.
Thank you very much, Dr. Hastings. Excellent presentation.
Thank you.
You've made it very clear. I just felt like I went through a mental exercise right there. But you did a wonderful job, and you made it very clear. And the use of your own personal cover test, as well as the video, has helped us tremendously. At this time, what we're going to do is we're going to hold the questions here. We're going to move on to Dr. Calder's presentation. Dr. Calder, who needs no introduction, will be speaking to us on technology and methods available for imaging of the eye at the GP practice. And we want to thank Dr. Calder again for putting this whole program together, getting his residents to be involved and teach us so well. They need to have excellent grades on their final exam because of how good they have done in their presentations today. So without further ado, I'll turn it over to you.
They most certainly will. Okay. Yeah, so, you know, so they left me with this topic, which is a rather interesting topic, because in ophthalmology, as you have seen from the presentations, imaging is very, very important. And so, and it begins from whoever sees that patient first. And I hope at the end of this presentation, we'll have a new appreciation for imaging. It would be interesting to know how many doctors do take photographs or images of anything regarding their patients. I'm sure some of you do, and we'll find out at the end. So image is an integral part of ophthalmology. It's part of the physics of ophthalmology, and from those from Fortis, we all loved physics, so unlike Ireland people. It allows us to record things, or findings in clinical ocular examination, because you know the eye is very small. Inside the eye is very dark, and things do change and move a lot. And we are looking at several nerves in a small space. But it gives us an objective and reproducible way of following things. We can now transmit things, and it can be stored in a durable way for later reference. And it's cost effective. So, and I already said some are essential for diagnosis, because with the improved imaging that we have, we can make diagnoses now based on imaging, and we can track things, and we can look how our treatment is working, and for long-term monitoring. And in the eye, it's one of the few places you can actually see blood vessels in the nude as they are, arteries and veins. We use ophthalmology. In ophthalmology, we use imaging for screening now a lot. For instance, there's a diabetic retinopathy screening, which makes evaluation of diabetic eyes more available and more relevant. So patients do not have to necessarily go into a clinic, but can be screened remotely. It also aids in teaching, as you see the excellent slides that the residents were able to present because of the images that were taken. They're very useful in clinical trials, in virtual clinics, and in today's real world, in telemedicine. I've employed telemedicine in my office now for some time, and so when this COVID came along, we just changed gear. Range and sophistication of ophthalmic imaging technologies have increased and has kept abreast of new technology, with computing running along, obeying Moore's law, where the computer speeds and capacities double every 18 months. You find that we can do more and more things as the years go by, and it becomes quite an economic challenge to keep up. One of the things that imaging brings with it, as with in ethics and so on, we have to be very careful of confidentiality and consenting patients to take and use their images. And we have to have a constant sense of that we secure and transmit patients' information in a secure way. Now, in ophthalmology, we tend to divide the eyes into front and back, and you have left and right. And so you do have specialists for the front and for the back, and for glaucoma and so on. And so we have imaging techniques for each portion of the eye. For the front of the eye, for the cornea, we can map the cornea like a geographic map. We do a corneal topography, and there are various instruments that are available. We can not only now measure the front surface, we can measure the back of the cornea, because it has some influence sometimes in how the eye behave and how disease is progressing, such as in conditions called keratoconus. We can measure the thickness of the cornea, pachymetry. We can look at the wave front of the eye for refractive errors and so on. We can use specular microscopy, where we use light to look at the endothelial cells and count them and look at whether or not they're of the same size or they're varying size or and shape. And this is very important in doing corneal grafts and in monitoring certain diseases. Confocal microscopy, while it can give us an image of within the cornea, within a discrimination of 1 micron to 4 microns, is not as popular because it's very expensive, but it lends itself to conditions like acanthamoeba infections. You can actually see the cysts within the cornea. For the posterior segment, color fundus photographs play a very important role, as I already mentioned, in diabetic retinopathy screening, in macular degeneration, in looking at hereditary diseases, in some drug toxicities such as hydroxychloroquine. We can do scanning laser ophthalmoscopy. They are now available ultra wide field, that is through a small pupil, you can see almost the entire retina. These instruments are not as widely available, but they are getting more so. We can look at the vasculature of the eye by injecting a dye called Fluorescein, and we can see the entire circulation within the eye. Not only do we see the blood vessels and the veins in a different way, but we can actually see how it flows, how efficiently it flows through, where there are leaks, and you can then monitor response to treatment. Fundus autofluorescence is something that is now being used more and more to look at certain disease processes such as macular degeneration, because there are certain things in the eye, such as lipofuscin, which is a breakdown product of the pigmentary epithelium, which autofluoresces, and you can see whether or not it's present in some condition. But the thing that has really, really changed ophthalmology and moved it into a new sphere is optical coherence tomography, which uses light interference, whether it is the wavelengths or the spectrum of light, that is the frequency. To distinguish what's happening in the vitreous, within the layers of the retina, we can now see all layers of the retina. We can see the choroid in detail. It's like you're looking at a histological specimen. And in the cyanin green, instead of fluorescein, we can see choroidal circulation that much better. Now they have available optical coherence tomography, which can now show you the small blood vessels. It's a very new modality, which is going to become more popular. But for now, the returns on investment isn't that great, so it's not as popular, as widespread as OCT. Almost every ophthalmologist now has access to an OCT. Now, for external and oculoplastic and adnexal imaging, you saw what you can monitor videography of the start there, because you just saw an imaging of extraocular movement. You can do color photographs of lesions around the eye, or you can look at somebody with a ptosis or bags under the eyes that we also operate on. And it's recommended for oculoplastics that you document your images before and after, because some people will not believe that they really changed, or they don't believe that you didn't get the look that they wanted or something like that. Ultrasonography is also extremely important, because when you have an eye where you cannot view the posterior pole, you can get an ultrasonography image, which can tell you whether it's a tumor or whether it's just a retinal detachment or it's diffuse vitreous hemorrhage. But it's also a very useful form of imaging. When you collect your images, you now may look at networking. How are you going to store them? We're going to archive, how you're going to communicate. If you now are using electronic medical records, how do you get these images into the patient's records? Do you need to? And you need to, as I mentioned before, now govern how you monitor and keep patients' information. So the images now forms a part of the patient's record. Your staff must be aware and follow the confidentiality procedures of image taking. They should not leave images up with persons' names beside it so others can now look and say, I've never known have a squint. Particular care should be taken with images used for teaching purposes, and consent must be gathered, and how you store them on your laptops and memory sticks and so on, and portable devices. And once transmitted, it's best deleted and left in the patient's records. And transmission of images should be best encrypted. Now, what does a general practitioner need imaging for? Well, I think a lot of that has been answered already. In the time of telemedicine, you can now communicate with each other, with your specialists, by providing images, and you're doing telemedicine. A smartphone is a worthwhile investment in your office for just that purpose. The smartphone by itself has gotten so good. When I started, I used to walk to work with a 35mm camera every day just to get the images that you probably saw once in a lifetime. I then got digital cameras, which worked very well. But now you just walk with a cell phone. And some of the images you saw earlier on were most likely taken with cell phone. Now, the thing is that sometimes the skill of handling the cell phone, the residents have gotten extremely good with it. They can take images from any angle through any device, and they look real good. But sometimes it helps if you have an adapter, something that holds the phone for you or makes the image, things more stable so that you can get a good image. And there are such devices. And I'll go through one of them, and then I'll also go through a scope, which is designed just for taking images of the eye. And they are now not as expensive as they were before. And it's something worth considering if you think you're seeing enough patients to warrant it. So let's start with how to use a smartphone. I have a little video clip here to get the anterior segment is quite easy. But the posterior segment is a little challenged.
The optics of fundus imaging using a smartphone camera is similar in principle to a retina examination with an indirect ophthalmoscope. In smartphone retinal imaging, the smartphone camera's coaxial flashlight and a handheld high plus power lens create an indirect ophthalmoscopy-like system that is able to record high-resolution digital retinal images. The portability of smartphones makes smartphone retinal imaging a promising technique for emergency rooms, telemedicine consulting, and retinal disease screening programs. For example, these flame-shaped and dot and blot retinal hemorrhages were photographed in a patient with non-proliferative diabetic retinopathy in a hospital emergency room. In this image, recorded in a hospital floor consultation setting, blurring of the optic disc margins in a patient with non-arteritic anterior ischemic optic neuropathy can be observed. Smartphone fundus photography may appear a challenging technique in the beginning. However, like any other examination technique, mastering the technique needs practice, and the process of smartphone imaging of the retina becomes routine with time.
And that is true. It really just takes practice. Now I move on to the smartphone adapters. Now I know I chose this one because I know several doctors already own these panoptic ophthalmoscope. And there is an adapter which is called Eye Examiner, which is made just for this instrument. And you have the appropriate iPhone, and there is a software which you get from the App Store, the Eye Examiner, which allows you to store the images for left and right eye. You can then manipulate the images. You can label them properly and archive them. And there are several of these devices now, or adapters for phones, that can make you image the eye pretty successfully. And Welch Allyn has a well laid out video and training section for this device. Now, the other device is a scope called Optomed, which is one of many. Zeiss has one, Volk has one, but it's meant to make life that much easier by everything built in. So here we go. And this one, the eye doesn't have to be dilated. It's a non-mydriatic. And there are different models. There's one that you can actually do fluorescein angiography, but for most GPs you don't need that. You just need the one that takes images. And you can archive and share them. They each come with their own software. And so imaging is quite good, but here I'm showing you an image that I took with a phone. And this was taken through my slit lamp though. But you can see there's a high femur in this person, which you're all familiar with now. So I don't have to tell you, but this person had no trauma. They had a condition called rubeotic glaucoma. If you look here, you see a little bit of blood clot hanging here. And if you look carefully, if your imaging is good, you can see that there are blood vessels on the iris. You see this sometimes in end-stage diabetes or in any condition where there is poor circulation in the retina of patients. And so it can, if somebody came to you with a painful eye or blood in the eye and you sent an image like this, we'd know exactly what happened there. Here is a cataract, which has become hypermature and has absorbed. So most of the contents, so it's just left with the anterior capsule and the posterior capsule. Here it is, and the posterior capsule is anterior, posterior, but this just slowly over time became hypermature. The capsule started leaking and all the proteinaceous contents leaked out. And this was photographed with a phone. This was recent of a pterygium, which had spontaneously avulsed from the person's cornea. They just come and said, my eye is feeling gritty. And they had a pterygium, and you can see where it is separated. And this was taken with my iPhone. And with the new phones, which has macro and so on, you can go quite close and get outstanding images, which you can then share and get information on. This case is a special case. I was at the end of my list for one night, and a call came in to say, I can't leave, there's an emergency coming from the airport. And this gentleman, I was out of his head. And they sent along an image. And when I saw it, I said, oh yes, he needs to come now. But the important thing about this one, as a teaching point, is that this person needs to come now. You cannot pad this eye. You have to leave it open. You can probably provide him with saline and some anesthetic drop just to keep it moist. But you should not put an iPad or gauze on top of this eye. You'll not damage his cornea and make his condition worse. So he came in, we relaxed the muscles around his eye and replaced his eye in the socket. He was walking with his cell phone and walked into something and stuck him here. You see that lesion is, which popped out his eye. So photography is very important in life. And imaging is very important, and so in ophthalmology, it's ultra important. So thank you.
Thank you very much, Dr. Calder. That was, sorry, are you hearing me?
Yes, I'm hearing you.
Okay, that was very impressive, especially since I have one of those panophthalmoscopes. So I'm going to get myself the adapter.
Yes.
But yeah, it's been very challenging to figure out how to examine the eye properly and without coming close.
Yes. And the images are great. You really, it makes, I've been doing it for years, and in the clinic now, it's routine.
Yeah, that's fantastic. So the Optomed, I look into the Optomed. The Optomed looks a little bit easier.
Yes, there are several like there. There's Pictor from Volcan. There are several. Just look for the one that suits you best, and they work well. You can really objectively monitor your diabetics, for instance, and make appropriate referrals. You can, and some of them do both anterior and posterior segment imaging.
Wonderful, wonderful. For now, I'm just going to send you all my cases.
Yeah, okay.
I'm looking to see if there are any questions here.
Any questions on the previous presentations that anybody has no doubt about? I'm here to. I resident calling for me, but
we have a question here. Is Nevanac a good anesthetic eye drop?
Nevanac, yes. Yes.
Okay, good. All right. And what are the differences between a chalazion versus a meibomian cyst versus a sty?
Okay. A sty, let's start with the last one, is really a cyst forming around the cilia, the eyelash. And so it's usually, and the eye is divided into two plates, anterior and posterior. And there's a gray line at the edge of the lid between the mucous membrane and the skin. And within these two halves, you have two different sets of glands. In the posterior half, in the mucous side, where you have the tarsal plate, they are the meibomian glands. Then the anterior aspect, you have the cilia with the sebaceous glands around it. And there are some other little glands of Moule and Zeiss. But those are the two important ones. So the sty is up the front. Now the chalazion forms in the meibomian glands. And it usually comes about sometimes in association with blepharitis or just allergies. And it's a kind of granulomatous collection within the gland. And it has been treated with both steroids and incision and curettage, but by the most common way is just to warm compresses and massage and time. And some topical antibiotic, usually tetracycline or fluorescein. While the sty is, again, just warm compresses and massage. There's an important component which is often overlooked, but it's becoming more popular. It's a mite called a Demodex mite, follicularum, which is found in these glands, and it can be treated. But people have chronic blepharitis, and it was treated very conservatively, but now it can be dealt with. But let me go back to the question, sorry, I deviate. So the chalazion is in the meibomian glands, and if it becomes infected, it's called an hordeolum.
Okay.
That's the term you'll see. And so sometimes the patients may need antibiotics. The popular antibiotics for blepharitis and that kind of thing is the tetracycline group, doxycycline.
Yes.
Like 100 milligrams once or twice a day, and that's it, along with the lid cleaning and so on.
Okay, wonderful, wonderful. I see Richard Reed says, thanks, Dr. Calder, for an eye-popping presentation.
That sounds like Richard, yes.
Okay, any questions? Any other questions? I'm not seeing any questions. Any questions for Dr. Hastings on squint? I think everybody is pretty much still have 228 participants on, so maybe they're having lunch.
Possibly.
Well, let's see here. How are you managing with your patients? Are you doing a lot of virtual consultations?
We started out in the lockdown doing a lot of that. And some of the patients were happy, but with the nature of some of the chronic diseases we have to see some of them, but we space the appointments, and patients are quite okay with the virtual thing and so on. And we use WhatsApp is supposed to be encrypted, and so we can speak to the patients directly with that. I've actually got a phone just for the office with its own WhatsApp address, and we then can communicate that way. And
Yes.
we maintain the distance, and everybody wears a mask. If you have to go close to the patient, we use a bit of tape across the mask and across the nose, which then stops the breath coming up. You have to go close, because what we saw was that the slit lamp, or when we were testing for glasses, everything got fogged up because your breath kept coming up above the mask. So by taping it, putting a bit of tape around, seals it off, and that works well.
So you just use some micropore over the top?
Or? Yes, and just tape across it. You'll see it happen with your mask too, with your glasses fogging up.
Right, yes.
So you tape across the top and stuff.
Great, wonderful. All right, I'm still not seeing any more questions here. So I think we are good. So let me proceed right along to the vote of thanks, and to thank you especially for organizing. Say that again?
No, I'm not. No, that's not me. I'm okay. That's a rain.
Yes, I'm hearing an echo. But thank you very much for organizing this wonderful presentation. You have a fantastic set of DM residents. They all handle themselves very competently, and they were very clear in their presentation. So you're doing something fantastic at the DM program there. And we are so grateful for just feeling so much more confident about what we should be doing in our private practice and who we need to refer to you, and a little bit more confident about our ophthalmic examination being done safely. So thank you once again to you and your team. We also want to thank just our executive. We want to thank Donald for an excellent job in putting this whole series together. We want to thank Sam Heron for executing this Zoom platform in such an efficient manner. It was a little bit more technically challenging the last time when we had to meet at Alhambra and do a half and half, but I think this is the way forward. And with over 225, 228 participants, it's the most effective way to reach everybody and to have an excellent presentation and to not have anybody put out unduly. We also want to thank Lynn, who is in our secretariat. She does a fantastic job in putting everything together. Thank you, the AGP members, for your support, for coming on, and for the excellent questions that were asked. And we pray that you will enjoy the rest of your rainy Sunday afternoon, whether in bed or otherwise. And to our sponsors who made this possible, we are grateful for your continued support of the AGP and our programs, and we were happy to have you. Thank you very much for your informative presentations, and have a good afternoon. Thank you very much to one and all.
Thanks very much, Peter, for co-hosting, and I must add my thanks to the presenters and the sponsors, and especially Lynn at the administrator. And thanks very much, Sam, for the very smooth manner in which everything has been done. And thanks to all the members for attending and viewing. And we hope to see you soon, and keep safe. Thank you very much.
you.